നമസ്കാരം.
നമസ്കാരം.
നമസ്കാരം. നമ്മുടെ ലൈവ് സ്ട്രീമിംഗ് തുടങ്ങിയിട്ടില്ല കേട്ടാ.
ആയില്ലല്ലോ, സമയമായില്ലല്ലോ അല്ലേ?
ഒരു മിനിറ്റ് കൂടെ
ആണോ? 5 മിനിറ്റ് ഇല്ലേ? 6:55 അല്ലേ? ആയില്ലേ, 1 മിനിറ്റേ ഉള്ളൂ. ശരിയാ.
എന്താണ് ദീപു, ഇതെന്താണ് എക്കോ പോലെ കേൾക്കുന്നത്? അർജുന്റെ തലയുടെ ഹൈറ്റ് കുറച്ച് ശരിയാക്കിയാൽ കൊള്ളാമായിരുന്നേ.
എങ്ങനെയാണ് ജ്യോതി?
കുറച്ച് ഗ്യാപ്പ് കിടക്കുന്ന. യെസ്. ഇപ്പൊ കൊള്ളാം. ഓക്കെ ഫൈൻ. ഓക്കെ ഡൺ. So let us start.
Good evening and welcome to the World Diabetes Month JPEF Mini CME Virtual 100 Years to Insulin Series 1. To begin with, I would like to invite Ms. Gopika Krishnan, who is Director of Academics and Research, Jodev's Diabetes Research Center. Over to you, ma'am.
Thank you, Anjana. So good evening, respected doctors and friends. A warm welcome to each one of you to the World Diabetes Month Jyotir's Special Education Forum Mini CME, organized by JPEF in association with Indian Medical Association IMA AMS Nimam chapter under the aegis of P. Keshav Dev Trust. As we're all set to commemorate 100 years to insulin discovery next year, we are proud to theme this CME as 100 years to insulin, which will be the first in series of the mini CMEs planned in the coming months. We are blessed to have a distinguished line of faculty today with us who will enlighten us on the newer aspects of diabetes management. So this program will follow a different format altogether so as to facilitate maximum fruitful discussions. So I once again welcome all of you to this evening CME. Now I request our anchors Beena and Anjana from the research department to take the sessions forward. First, let me request Anjana to introduce the chairperson for the first session. Over to you, Anjana.
Thank you, ma'am. To begin our technical session, I would like to invite Dr. Arun Shankar, who is the Senior Diabetologist and Medical Director of Jodev's Diabetes Research Center. Over to you, sir.
Good evening. Once again, on behalf of JPEF team, I would like to welcome you all to this World Diabetes Month Mini JPEF CME virtual. And these days, we are all more interested to hear about vaccine. Of course, in this pandemic situation, we are concerned about, or we are eager to know about vaccines right now. But whenever we discuss about adult vaccination and the adult vaccination schedule in diabetes patients, of course, we have to give importance to a few vaccines which we commonly use in diabetes management. So, being a diabetes month, World Diabetes Month program, of course, realize the importance of discussing vaccination in diabetes. So to discuss about the first topic, we have the right person with us. I would like to introduce our first speaker, none other than Dr. P. Arjun. He's alumnus of Trivandrum Medical College. He's the senior consultant and group coordinator, Department of Respiratory Medicine at KIMS. The member, Nodal PMDT Committee for South Kerala. He has been trained in Asthma Academy, Christchurch, New Zealand, under Professor Richard Wesley, and he is also trained in sleep medicine. He's trained in interventional pulmonology, and he's an international invited speaker at national level. He has presented more than any number of original research papers in ERS and CHEST meetings. He has many areas of interest, include asthma, airway disease, sleep disorders. First speaker, and he'll be discussing on influenza vaccination in diabetes. Over to you, sir.
And in addition, we know each other for several decades, and Arjun is the best person we can have for this part topic. Welcome, Dr. Arjun, for our CME.
Thank you. Thank you, Dr. Arun, for the nice words of introduction. I hope I am audible also.
Very much audible.
And can you see the slides? Are they seen now?
Yeah. Slides are screen. You need to just make it full screen.
Yes.
Yeah.
Is it okay? Thank
Perfect,
you.
perfect.
Let me at the outset thank Dr. Jyoti Dev for having given me this opportunity to speak in this CME here today. Dr. Jyoti wanted me to speak about the role of influenza vaccination in diabetes, but I thought I'll slightly stretch the topic a bit more. And maybe I thought I'll speak on influenza vaccination, what one really needs to know. No, the agenda for today's talk is I will just start with a brief introduction of the disease influenza. Then we will go on to see the influenza vaccine, in particular, the types of vaccines that are available, who is the right candidate to get the vaccine, when to vaccinate, what are the contraindications, a few FAQs regarding influenza vaccine, which commonly are asked to all of us by our patients. Then we will see a bit about diabetes and influenza and the relationship between these two. And finally, no talk these days is complete without mentioning COVID. And so we will just end with a couple of slides on COVID and the importance of influenza vaccination in the COVID era. So we all know that influenza is a common disease which affects mankind throughout the world. It is assumed that 5 to 10% of the world population get an attack of influenza every year. And what is more important is it causes a lot of hospital admissions and even deaths. 250,000 to 5 lakh deaths annually have been attributed to be caused by the influenza virus. Now we know that influenza virus is an RNA virus. There are 4 types of influenza virus, but the main ones are influenza A and B, which cause seasonal epidemics. Influenza C sometimes causes mild respiratory illness, but as far as we are concerned, clinically important ones are influenza A and B. And A again is subdivided into many groups based on the two proteins which are being found in the coat of the virus, the hemagglutinin and neuraminidase base. So you have many combinations of H1, H2, N1, N2, so that you have many permutations and combinations which are possible. And these can also be reassorted between strains, and that results in development of newer subtypes of viruses which cause epidemics frequently. Now, this a word about the taxonomy of the virus. When you talk about the influenza virus, you sometimes get to read something like this. For instance, this says A Fujian 411-2002 H3N2. So what does this really mean? It basically means that this is an influenza A virus. The geographic origin of this virus is Fujian in China. The strain number is 411. It was first isolated in the year 2002. And the virus subtype, this is a H3N2. And this H3N2 is based on the hemagglutinin and neuraminidase proteins that are found on the envelope of the virus. We are all familiar with the symptoms of influenza. Basically affects the upper respiratory tract. You have systemic symptoms like fever, respiratory symptoms like cough, affects the gastrointestinal tract. You have diarrhea, vomiting, and of course, extreme tiredness, joint pains, aches, and headache are all are associated with influenza. It is important that you should make a clear distinction between influenza and the common cold. Common cold, again, is something which we commonly happen to see. The typical symptoms here are stuffy nose and sneezing. A mild cough is there. Usually fever, headache, and other symptoms are absent or very mild. In contrast, in influenza, patients usually have high fever lasting for days together with headache, myalgia, fatigue, weakness, extreme exhaustion, and severe chest comfort and cough. So if these red flag signs are there, you are probably dealing with a patient who has influenza, not the common cold. It is also important to realize that influenza is associated with development of a lot of complications, ranging from pneumonia, ARDS, secondary bacterial infections, myositis, cardiac complications, encephalopathy, and even Guillain-Barré syndrome. So it is all the more important that we have some tool with us which will help us prevent development of influenza, and thereby preventing the development of influenza, we will be able to avoid the complications which are associated with the disease. And that tool which we have with us is the influenza vaccine. Now, the question which often comes is, why should one take the flu shot? And the answer comes from this data sheet of CDC, which was released earlier this year. In 2019-2020, they found that with the use of influenza vaccine, they were able to prevent 7.5 million flu illnesses in the United States. They were able to avert more than 1 lakh hospitalization because of flu, and even 6,300 deaths, which essentially means approximately 17 people die per day because of flu if they are affected, and that can be effectively prevented by the use of the flu shot. So this highlights the importance of taking the flu shot regularly. Now, seasonal influenza vaccine has also been noted to reduce the likelihood of developing influenza illness, which necessitates a hospital visit by about 60%. Even at all, if the person develops influenza after taking the vaccine, the severity will be far, far less. And it also reduces the transmission of infection to other people. It has also been very clearly shown that influenza vaccine reduces influenza-related pneumonia by about 60%, influenza-related hospitalization by 50%, and even influenza-related deaths by about 75 to 80%. So there is strong data to support the use of influenza vaccination on a regular basis. Now, when we look into the evolution of the vaccine, the influenza type A virus was first isolated in 1933. Within 5 years, the first monovalent vaccine was introduced. The next decade, the first bivalent vaccine came. In 1978, the trivalent vaccine came, which has 2 strains of influenza A and 1 of influenza B. And for about the next 30 years, that was the vaccine which was most prevalent and most popular worldwide. Till in 2013, the quadrivalent vaccine came, which is the one which we regularly use these days, which contains 2 strains of H1 of influenza A and 2 strains of influenza B. Now, the types of flu vaccines can be classified based on how they are produced. It could be egg-based, it could be cell-based, and it could be recombinant flu vaccines. So when we talk of influenza vaccines, there are 2 major groups of vaccines. One is what is called the inactivated influenza vaccine, or IIV, which is the one which is most popular and is the most commonly used vaccine worldwide. You also have the live attenuated vaccine, LAIV, or live attenuated vaccine. Inactivated influenza vaccine is the most popular one, most commonly used and worldwide. It is usually given as intramuscular injection, and it can be used for a wide variety of people without any significant contraindications. In contrast, the live attenuated vaccine is given as an intranasal route of administration, but it is not suitable for a large group of people. People who are immunosuppressed, who have immunodeficiency, cannot take the vaccine. People who have asthma or wheezes cannot take the vaccine. So a lot of contraindications are there for that, and it is not very popular. And there have been some studies which show that it may be associated with some dreaded neurological complications as well. When you talk with the inactive influenza vaccines, again, there are 3 types. The whole virus vaccine, that is, the vaccine contains the whole virus, which is now been largely replaced by less reactogenic vaccines like the split virus and the subunit vaccine. Of this, split virus and subunit vaccines are the ones which are commonly used these days. And of this, the split virus vaccine is the one which has the most propensity to develop immunogenicity. So you get the best results if you use a split viral vaccine rather than a subunit vaccine. Now, what are the various vaccines which are available in our country today? We have the trivalent vaccine, the quadrivalent vaccine, and the live attenuated vaccine is also available. But as of today, the most popular one is the quadrivalent vaccine. Now, the quadrivalent vaccine, as I told you earlier, contains 4 strains. There are two strains of influenza A, which essentially are, one is H1N1 and the other is H3N2. And then you have two B strains, which are essentially derived from two lineages of influenza B, the Victoria and the Yamagata lineage. For instance, if you look into the present, currently used influenza vaccine for the 2020, 2021 year, you have influenza A, the Guangdong strain, which is the H1N1 virus. Then you have the influenza A Hong Kong, which is the H3N2 strain. Then you have the two influenza B viruses. One is the Washington, which comes from the Victoria lineage, and then you have the Phuket, which comes from the Yamagata lineage. So this is how a quadrivalent vaccine content looks like. You have two two A strains and two B strains. Now, what is the reason why this quadrivalent vaccine has now come into use and it is more popular than the trivalent vaccine? The reason is that because of the knowledge that influenza B is also equally commonly present throughout the world. If you look into the global circulation of the virus, this is in the year 2018, you can see that what is shown in brown and yellow are of the influenza B virus, and what is shown in blue is the influenza A virus. You can see that influenza B strains are also equally commonly found throughout the world, similar to the numbers of influenza A. So if we use a trivalent, actually, we will be missing a lot of strains of influenza B, and hence the coverage of the vaccine will not be adequate and the efficiency will not be as to the level of expectations. And the similar scenario in India is no different either. In India also, there are a lot of places where the influenza B vaccine is very, very commonly found in the causing influenza-like illness. Now, over a period of 30 years, it has been shown that influenza B causes about 25% of all the influenza illness is caused by influenza B, and influenza B strains also are a major cause of seasonal flu epidemics. They cause absenteeism, hospitalization, and even death. And it has also been shown that overall mortality associated with influenza B virus was greater than even H1N1. So that is the need why you have to adequately cover influenza B, and a quadrivalent vaccine, which contains two strains of influenza B, is far more effective than a trivalent, which contains only one strain of influenza B virus. Now, what do the physician bodies and societies in India recommend? These are the 2017 recommendations. API and IECS, Indian Chest Society, said at that point in time that there is insufficient evidence to use influenza vaccine on a routine basis. But things have come a long way now, and now in 2020, all of them have given a strong recommendation for use of this vaccine on a regular basis. Now, the next question is, who should get the vaccine? I have taken this from the recent Indian Chest Society guidelines, which came in August 2020. So they say that the person is more than 50 years of age, vaccination is strongly recommended, especially if the patient is at a high risk for developing influenza. On the age group between 18 and 49, the decision to vaccinate is based on the discretion of the doctor as well as the choice of the patient. So more than 50, high risk, please go ahead and vaccinate the patient. And who are the high risk patients? There are a list of conditions which have been indicated as high risk. And the first and topmost of them is diabetes mellitus, with or without other comorbidities. We have other patients having chronic lung disease, chronic liver disease, chronic kidney disease, chronic heart disease, patients who are immunosuppressed, who have malignancy, who are on treatment. Healthcare workers are a very important group who are always at high risk of developing influenza. Then you have pregnant women, patients with morbid obesity, and all these people really fall into the category of high risk people who are at high risk of developing, of contracting influenza, and they have to be vaccinated on a regular basis. Another important but often overlooked group are the people who go for travel and holy pilgrimage. For example, people who go to perform Hajj and Umrah every year. Because of the mass gathering there, they are always at a high risk of developing respiratory infections. And in our country also, we have the Kumbh Mela, where there is a massive gathering of people. And at such places, it is always wiser and it is always advisable to vaccinate those who are going for these pilgrimages with the influenza vaccine, which is available at that point of time, at least 2 weeks before they undertake the travel. So this is a major group of people who develop respiratory illnesses because of virus, and which can be prevented. Another important question which often comes is, when do you give the vaccine? Is there any particular time of the year when you have to give the vaccine? So, and the answer to this is a bit tricky. So, for example, if you take the United States, you have what is called the flu season. that happens every year, almost on a constant basis. From December to March, you have the flu season. And so if you are in the United States, if you take a flu shot somewhere between September and October, you are almost sure that you are protected from getting the flu. When we look into the global pattern, this is what we see. In the northern hemisphere, that is above the 40-degree north latitude, you have the influenza activity peak from November to March. United States falls in this area, and hence, as we saw earlier, this is the time when you have the flu season or the active flu period. When you come to the southern hemisphere, you find that the influenza activity peak is between April and September. But there are certain countries which fall in the tropics where there is an year-round activity of influenza illness or the virus activity, and India typically falls in this group. And it has been shown that in our country there is no flu season, but around the year you get attacks by the influenza vaccine. There are some recommendations by the Indian guidelines as when to give the vaccination, depending on some locations, and the studies they have done. And the proposed timing for vaccination different cities in India is April to May. Places in the north of the country, like Delhi, Lucknow, Kolkata, Pune, Dibrugarh, you give it in April and May. And some places like Srinagar, Chennai, and Vellore. Srinagar typically because it falls in the temperate climate, and they have the typical flu season there. But Chennai and Vellore surprisingly also fall in the second group of September to October when the vaccination is to be given. We have also done some studies in this area, and this is data from our hospital, from KIMS Trivandrum. We looked into the etiological and clinical profile of virus-associated community pneumonia in adults, and we presented our paper in the CHEST Congress 2020, which was held in Italy earlier this year. And I will share some data from this paper, which makes some interesting observations. We looked into the influenza activity pattern of 3 consecutive years, 2017, 18, and 19. In 2017, as you can see here, we found that there were 2 major peaks of influenza illness. So you had a peak in January, February, another peak between May and July, and then a smaller peak in October. Whereas when it came to 2018, there was only 1 peak, and that coincided with the onset of winter. October, November, December was the peak we had in 2018. Whereas in 2019, the influenza peak really happened with the onset of monsoon. It was in June, July, August that we had the peak number of influenza cases. So as is demonstrated here, we really do not have a fixed flu season in our part of the world. And hence this keeps on varying. But what is interesting is that you have influenza activity keeping constantly at some point of time throughout the year. And hence, what I would suggest is that our patient should get a flu shot at least in some point of time, rather than getting no flu shot, thinking about when to give and then forgetting to give. Will not make any sense. They have to have a flu shot ideally. And in our experience, what we have been doing in the past 10 years or so with the advent of influenza vaccine, with commonly in our country, is we have been usually giving the vaccines between September to November. And our results have been extremely good as far as preventing influenza is concerned with keeping in this thing. We also found in the study that in the first half of every year, we found that there was almost always a peak of influenza B and the rhinovirus infection. Whereas in the second half of the year, which is significant for the part that you have the monsoons coming in from June, July, and then the second rainy season in October, November, and then with the onset of winter, there are more cases of viral infections as compared to the first half of every year. 2017, we found respiratory syncytial virus, metapneumovirus, and H3N1 as the common viruses that were present in that year. Whereas in 2018, we found that the most common virus which we were able to isolate was H1N1. So that also shows that almost all spectrum of viruses are present even in our part of the world. And most of them actually, apart from influenza, really do not need any treatment, but they can also cause symptoms similar to influenza. Another question which is usually asked is, can it be given along with other vaccines? The answer is yes. The vaccine which we commonly administer along with it usually is a pneumococcal vaccine. Only thing is that both are kill vaccines, so they can be given at different anatomical sites. Deltoid is the area where usually you give the vaccine. You give it on one hand one vaccine, other hand you take the other vaccine. But other thing is the live attenuated vaccine, if you are giving any other live vaccine like the zoster vaccine, there should be a gap of at least 4 weeks between the 2 live vaccines. The next question is, I have taken one flu shot. Should I keep on repeating it again and again, year after year? Why should it be taken annually? And the answer comes from two phenomena which are commonly seen with the viruses. That is the antigenic drift and antigenic shift. A small minor change in the protein pattern can cause an antigenic drift. Antigenic drift usually ends in epidemics, whereas a major genetic reassortment leads to antigenic shift, which can lead to the pandemic. And the last pandemic of influenza which we had was in the year 2009. Are there any contraindications to take the vaccine? There are two contraindications which one should keep in mind. Number one is previous history of severe allergic reaction to the vaccine is a contraindication not to give the vaccine again. And the other contraindication is those who have experienced Guillain-Barré syndrome within 6 weeks of the previous influenza vaccination should never be given, although this is an extremely rare complication. And in the last 10 years, I have not even come across a single person who has developed this complication. Previously, it was thought that egg allergy is a contraindication to give the vaccine, and those who had egg allergy we specifically used to ask patients whether they have egg allergy, and if they have allergy, we never used to give them. But now we have good evidence to suggest that even those who have egg allergy, those who develop urticaria or even angioedema after taking egg and who have allergy to that, they can safely be given the vaccine without any complications. What are the possible side effects? There are no major side effects with the vaccination. Soreness at the vaccine site is something which is reported once in a while. Redness with or without swelling where the shot was given has also been observed very rarely, but nothing like high fever and other flu symptoms, nothing has ever been observed at all. Something else which is commonly asked is, can the vaccine be taken when there is a concomitant respiratory infection? If the infection is mild, like a simple URI, you can certainly take the vaccine at the time when you have the ongoing URI. But if you have a moderate to severe infection, the answer is a clear no. You have to wait till the infection subsides, wait for a couple of weeks till the immunity comes back to normal, and then you can give the vaccination. Having seen all this and having seen the effectiveness of the vaccine, the big challenge that we face in our country is the reluctance of the patient to accept the vaccination. So what is the barrier to the acceptance? And this is something which is common worldwide. And there are some studies which have been done in our country as well. This is a KAP study, that is knowledge, attitudes, and practices about influenza vaccination among healthcare workers in a medical college in Srinagar, done by Dr. Parvez Kaul's group. They had certain interesting findings from this study. 85% of the people who were enrolled in the study knew that influenza is a potentially severe disease. 60% knew that a vaccine was available against influenza, but only less than 5% had ever taken the vaccine. So although there is awareness, when it comes to the ground reality of taking the vaccine, there is a big gap, or there is a big vacuum. And when they were asked why they have not taken the vaccine, there were a lot of reasons which came up. Some believed that the flu shot is not effective. Some were afraid of the unpleasant side effects, whereas some others were stupid enough to believe that they are not at risk of developing influenza at all. So there are a lot of thought processes which are there among patients. And as healthcare providers, it is our duty to ensure that these misconceptions are removed and influenza vaccination gets a bit more popularity, and it is given because of its effectiveness as well as cost effectiveness. The same group looked into influenza and pneumococcal vaccination patients with diabetes. They found that less than 10% of the patients whom they studied really had taken vaccination for influenza and pneumococcus. This is despite the fact that almost 100% of the patients were told by their caregivers that it is good to take the vaccination. Coming to diabetes and influenza, it's one of the pet theme of Dr. Jyoti Dev, and he is very passionate about it. What is the impact of influenza on patients having diabetes? We know that even a clinically minor infection will induce uncontrolled blood sugar levels, and that can actually predispose them to develop infections. Influenza infection actually causes an imbalance in the metabolic control, and there is a two-way relationship between this and impaired immune response, which will make the patient more vulnerable to develop influenza infection. When the patient's diabetes control is gone, they run the risk of developing acute metabolic decompensation, including diabetic ketoacidosis. And those patients who develop ketoacidosis are at higher risk of certain invasive infections, including invasive fungal infections and severe bacterial infections. Metabolic complications, decompensation, ketoacidosis, and even deaths can happen if the sugars are not properly controlled and the patient develops a simple infection like an influenza, which can have a profound effect on the patient's health in total. It has also been shown that influenza is more frequent and more severe in patients who have diabetes. Patients with diabetes are more likely to be hospitalized because of influenza. There is a 3 to 6 times higher risk of getting hospitalized during an epidemic. There is a 30 to 90 times higher relative risk for death during hospitalization. Post-influenza complications, 6-fold increase in risk, and increased incidence of ketoacidosis has been noted during the epidemics years in which H1N1 epidemics have happened or influenza epidemics have happened. This is a study from the UK looking into diabetes as a risk factor for influenza complications. They found that like COPD, like cancer, like other cardiovascular disease, diabetes is also an important risk factor for developing complications associated with influenza. They also found that when you look into the age-adjusted relative risk, there was almost a six times more risk of dying because of if the patient had diabetes and develops influenza. What about the clinical effectiveness of the vaccination in patients who have diabetes? This is from the PRISMA study, in which more than 75,000 patients were enrolled and studied. And there are very interesting findings from the study in which they were able to show that if you vaccinate a patient with diabetes, it produces a 56% reduction in all complications, 54% reduction in hospitalization, 58% reduction in deaths. And they also found that there is a 72% reduction in complications, especially in the adult age group 18 to 64, and 56% reduction in mortality in patients more than 65 years of age. And those who got a single vaccination did not do as well as people who got annual vaccinations on a regular basis. Another question which usually is asked is whether the immunogenicity of influenza vaccine is affected in patients who have diabetes as compared to non-diabetes. There have been a lot of studies in this, has been done in this area, and they have all clearly shown that there is no significant difference in the immunogenicity that is generated by the vaccine in patients who have diabetes as compared to patients who are non-diabetic. Basically means the vaccine is as effective in patients who have diabetes as compared to people who do not have diabetes. Influenza vaccine is very important to prevent cardiovascular complications also. And this is particularly important because diabetes again is a risk factor to develop cardiovascular complications. And from this landmark paper in the New England Journal, which appeared a few years back, they found that in the first week after developing influenza, there is a 6 times increased incidence of acute coronary syndrome as compared to the later period. So by giving influenza vaccine, by preventing in development of influenza, you are actually possibly averting acute coronary syndromes and acute myocardial infarction as well. So another question which is usually asked is most of the patients who have diabetes are on statins for lipid control. Statins are known to be immunomodulators. So if you give an influenza vaccine in a patient who is on statins, will it reduce the effectiveness of the influenza vaccine? This is a study done from Ann Arbor, and they have very clearly shown that if you use a statin or not, it does not matter because influenza vaccine is equally effective even if you are on statin and even if you don't take statins. So statins do not have any effect in reducing the effectiveness of the influenza vaccine. This is yet another study done by our group in KIMS Trivandrum, which looked into actually a slightly different thing. This is on COPD exacerbations, the efficacy of influenza and pneumococcal vaccination. And we presented our findings in the IDSA meeting in 2017. And what we found that as compared to the unvaccinated group, the vaccinated group had lesser number of exacerbations of COPD, lesser hospitalization, lesser ICU admissions, lesser need for mechanical ventilation, and a significant reduction in mortality as compared to the unvaccinated group. Again, showing this is some data from our own area, so that the efficiency, the effectiveness of the vaccine is really present in our part of the world as well. A couple of slides about COVID-19 and influenza vaccination before I end. Influenza in COVID times is very, very difficult because both the influenza and COVID have almost the same symptoms. So it becomes very difficult to distinguish influenza from COVID. And hence comes the importance of vaccinating all people so that at least you can prevent influenza and reduce the confusion that can happen. If you potentially delay the influenza vaccine at this point in time, what is going to happen is there is an increased risk of developing influenza over and above COVID-19. And that increases the hospitalization, complications, and cost of treatment. And also, people who develop influenza and come and wait um, in the emergency, come to the waiting areas of your OPD, they are at increased risk of developing COVID from the hospital itself. So what essentially the flu vaccine does is reduces the influenza burden. It frees up the healthcare capacity to fight COVID in a much stronger way. So finally, this is my last slide. There are a few take-home points before I conclude, and most of them relate to diabetes and influenza vaccination because that was what Dr. Jyoti wanted me to talk about. In 2019, the global prevalence of diabetes was estimated to be about 9.3% among adults aged 18 and above, and this still keeps on increasing. Influenza is much more frequent and more severe in patients who have diabetes, and this leads to increased risk of complications, hospitalization, and deaths due to influenza. We have seen that influenza vaccine is equally effective in patients with diabetes. The immunogenicity is not compromised at all as compared to non-diabetics. It is effective. There are a lot of studies that have been done, and even in diabetic adults and even in elderly persons, it has been shown to be effective. But the sad state of affairs is, despite the recommendations from various medical associations, national authorities, and international bodies, unfortunately, vaccine coverage is far, far less than what it really should be. It is much below the targets that have been set. And unless and until this improves, our patients are still at high risk of developing influenza and related complications, which actually can be easily prevented by taking this vaccine on a regular basis. I will stop here. Let me thank Dr. Jyoti once again for having given me this opportunity, and I am welcome to taking a few questions. Thank you very much.
Thank you, dear Arjun sir. That was a clear and crisp presentation. You are going through the topic in detail, and I think towards the end, what you had presented is among the take-home points, the last sentence that is important. And in the presentation itself, you have shown the data which shows that among the healthcare workers itself, they are not happy with this vaccination. So that's why I think we are not at all advising our patients as well, and we are also not being regularly using these types of preventive measures which we have to use right now. Thank you for the wonderful presentation. Jyoti sir, any questions?
Yeah, I think there are a few questions in the chat box. Let me ask Gopika. Yeah, can you read out, Anita? Because currently, how many are attending this program, Bibu? Any idea? The latest update from our virtual screen. How many doctors are attending this program, Bibu?
462, sir.
462. Okay. Arjun, 462 doctors have been listening to your presentation. Shankar, there is a question from Anita. Yeah. How far can flu shot protect a diabetes patient from contracting COVID-19?
Absolutely, we don't have any data as of today whether flu shot will prevent patients from developing COVID-19. I think there are some studies which are needed at this aspect. Probably about a year from now, we'll have at least some more data. If you go back and look at our vaccinated patients, whether they develop COVID or not.
Arjun, when compared to 10 years ago, do you think that the vaccine acceptance has gone up now?
Yes, certainly. To a certain extent, acceptance is much more, but particularly among the patients who have taken the vaccine, they have experienced the beneficial effects. No need to take frequent antibiotics, no regular respiratory infections, no hospital visits. There are many people now who just come once in a year to get the vaccine. All the other follow-ups are lost. So they are so happy with that. And such people actually motivate their friends and relatives also to come and take the vaccine. So it's by word of mouth that it's spreading. But I think from the health, from the medical societies also, I think we'll have to aggressively make a push to make this more probably if this gets included in the immunization program, national immunization program, perhaps that will be a major step forward.
That is why I will pick up one more question from the virtual platform. And this is a question on allergy. You have mentioned about allergy and a very, very, very rare occurrence of Guillain-Barré syndrome. And of course, egg allergy is not a contraindication now. But in the case of a patient with allergy to multiple drugs, are you justified in giving a test dose? And if so, how will you give?
Absolutely not. We have been giving this to patients who have been having multiple drug allergies, and basically they tend to tolerate this vaccine extremely well. So there is no point in giving a drug. So almost only 0.5 ml of that vaccine is available in that pre-filled vaccine. So it's very difficult to give a drug allergy, allergy test also. We never have had the need to do that. And we never have had faced, because since 2009 pandemic, we have been regularly using this vaccine on a large scale.
And the same experience, of course, Dr. Anishankar can share his experience, because we have been regularly vaccinating all our patients.
That's the great thing.
Actually, just like what Arjun sir mentioned about people coming for taking vaccination yearly once. And today also I had an experience while consulting a patient online. She was mentioning that she is unable to travel to our center to take this vaccine, and she's very sad that and feeling not comfortable without vaccination, whether she will end up with any infection or not. She's more concerned about that. So whenever we are advising our patients to take this vaccination and explaining in detail what are the benefits of this vaccination, definitely people are willing to take that vaccine. And of course, they are finding it very easy and try to avoid this sort of infection in this pandemic situation as well, to avoid hospitalization.
Very
so
true.
definitely it is helpful for all the patients who are indicated, definitely indicated.
Good evening, Dr. Jyotidev, Dr. Arjun. Arjun, can I just add a point? I'm one here.
Yes, sir.
The thing is that, finally, Dr. Arjun told one of the effective measures for overcoming that barrier is including that in the immunization schedule. But unfortunately, the point is that the periodicity of this vaccine and its cost is making it problematic for the governments to include that in the immunization schedule. But of course, professionals like pulmonologists can sort of lobby with the government to include that in the schedule, but not to be supplied free of cost. Some of the vaccines have found their places in the immunization schedules, but not being provided by the government. But I think influenza vaccine is yet to find a place in the immunization schedule, government schedule.
Yes,
absolutely, absolutely. That is right. And one good thing about our diabetes, Dr. Arjun, it has been included in the schedule by the American Diabetes Association around 7 years ago. And from this year onwards, we have prepared a consensus where we have RSSDA along with the ESI. So this is the first time we are preparing a treatment protocol together with the Endocrine Society, and the RSSDA is the biggest diabetes organization, around 9,000 to 10,000 doctors. And there, in the consensus, along with many, many other recommendations, influenza and pneumococcal vaccines are both included for diabetes. Of course, it is a very long paper, but it has been officially included.
That's a great
maybe
step
that
forward,
is a first step, Mohan sir. So maybe the next step we can recommend, and this has been included in the ICMR diabetes recommendations also, and that has been prepared last year. And there again, first time we have included influenza and pneumococcal for diabetes. And ICMR, it has been drafted by Dr. Mohan sir along with the group from India. So this is good news. So Arjun, we learned a lot from you, as usual, as usual. Brilliant, excellent.
We have one more question.
Thank you.
From Dr. Nasimuddin.
Yeah, we'll take up that because we are,
Yeah. What about the patients 70 plus getting vaccinated? Do they develop adequate immunity?
I didn't hear the second part of it, Arun. Patients more than 70 years.
Will they develop immunity?
They certainly will develop immunity. Even very elderly people, 85 plus, have been shown to have immunity. But there are studies also which have been done and proven by looking into the HA titers that they certainly develop immunity.
And
but
the same
one more point, Jody, one more point which I'd like to add is since last year, for people who are more than 65 years, they have actually introduced a high dose vaccine in the United States. Perhaps a couple of years later that will come. Usually we give 0.5 ml. For people more than 65 years, they have now come with a new vaccine, which is 0.7 ml.
Okay, so probably we can foresee that also coming to India very soon. Okay, thank you very much. Thank you very much, Arjun, for your time.
Thank you.
Perfect, excellent. So back to Beena.
Thank you, sir. Thank you so much, Arjun sir, for the talk, and Arun sir for moderating the session. Now we have a momentary inaugural function. And for this, I would like to invite Dr. Jyotidev Keshavarep Chairman and Managing Director, Jyoti's Diabetes Research Centers, Kerala. Ms. Sunita Jyotidev, Executive Director, Jyoti's Diabetes Research Centers. Ms. Gopika Krishnan, Dr. Arun Shankar, and Dr. Mohanan Nair.
And Dr. Ashwin David is there, Prasad Shankar is there. Our chief guest today is none other than Mohanan Nair, sir. So Dr. Mohanan Nair, sir, is the Vice Chairman, Professional Protection Scheme of the Indian Medical Association, Kerala State. And he is also the chairman of the AMS chapter IMA Nema. But for us, he is our founder president of Indian Medical Association Nema. So over to our dear Mohan Nair, sir, for the formal inauguration.
So thank you, Dr. Jyoti, dear Dr. Jyoti, Mrs. Sunita, Dr. Arun, Ashwin, and all the JPF team, and all the respected faculty members and other doctors who have joined for this virtual CME, ladies and gentlemen. Actually, for me, joining a CME session for inauguration or whatever is joining my, say, family. It's my family. For some time, I had always been with all the programs of JPF here. And currently, we are going through times of crisis, not only in terms of this pandemic, but the modern medicine is actually in crisis, and most probably we are going to be in war path in a couple of days or in a week's time because of that issue of mixopathy. The whole medical profession is going to be on streets. Those are the signals that are coming right now. Even now, I had been attending a national meeting where there is a call for total strike because of the mixopathy issue here. So actually, I'll tell that pandemic had not been, at least in academic matters, for the people who are practicing diabetes in Kerala and in some part of India or world, this pandemic had not been a challenge because just as Jyoti has done, he has converted that challenge into an opportunity when he showed that a greater quantity of quantum of academic matters could be sort of transacted during this pandemic by doing that JPF conference, which had been a momentous success. And that had been followed by, I think, more of academic events that had been happening in the pre-COVID era. So during this pandemic, JPF had been conducting more of academic events for the sake of our practicing doctors. And in that matter, actually, we didn't face any challenge at all. So it's actually my pleasure to join you to sort of formally inaugurate this session. And I have a request at this time because from the side of IMA, because this year also IMA is taking up diabetes in a big way. And we are concentrating more on diabetic retinopathy. Being the pioneer institute in Trivandrum and also the sort of the leaders in diabetes management in India, and definitely in Kerala, I think Dr. Jyoti will take a very proactive role in sort of joining us. It's not joining us. We have to work together because you are already in IMA. Maybe in the my request is that from IMA Nema branch side, probably in collaboration with the JPF and Dr. Jyoti's Diabetes Care Center, we can do programs mainly on prevention of diabetic blindness, which is once again a slogan for this year for IMA. And actually, I in the beginning, as I told you, this is always a pleasure to be with you. And with these few words, I profusely thank all the organizers of this particular session for giving me this chance to be with you this evening and also attending some of the academic sessions, and declare that with your permission, this virtual CME is formally inaugurated. Thank you. Jai Hind, Jai IMA.
Thank you, sir. So I appreciate the nice words spoken about us and the JPF, and this is a program which is organized along with the IMA AMS Neman chapter, and we are aware of the fact of retinopathy being taken up by the IMA. Will definitely partner, sir, in a much more efficient way. And it is a truth that the number of virtual programs, the education events in diabetes has gone up by 2 to 3 times in the country. So it is much more in numbers in the country after COVID. So I spoke to certain people in the morning. So this and the number of doctors attending, it's close to 500 now. in the virtual platforms, that is also incredible numbers. When we are conducting a local program, it used to be around 45 to 50. So the numbers are also multiple. Yeah, 2 to 3 fold. Exactly. Okay. Thank you very much, sir. Yeah. Any comments, sir?
No, not at all.
Yeah.
Thank you.
Thank you. Thank you. Ashwin, welcome. Thank you. So over to Anjana.
Thank you, Mohan sir, Jyodev sir, and everybody for the blessed moment. Now we will move on, and next we have the theme symposium. And let me invite our moderators, Dr. Prashant Shankar. He is the consultant in internal medicine and diabetes, MGM Muthoot Hospitals, Pathanamthitta, and Dr. Ashwin David Ashok, the senior diabetologist and clinical head of Jodev's Diabetes Research Center in Artingal. Welcome, sir, and over to you. Over to the moderators.
Thank you for the introduction. Again, a big thank you to Jyotidev for giving me another opportunity at this forum. Good evening to Mohan sir, Dr. Arun, Dr. David, Sunita Madam, Gopika, and other team members of JPEF. So the theme for today's meeting is 100 years of insulin, and we will be moving with the first of those topics. Shall I share my slide?
Yes, Arun joined or not?
Sir, Arun sir will be joining soon, sir. He's having.
Yeah, okay, fine. Yeah, Dr. Prashant, you proceed.
Yeah.
I have joined. Hi, Jyodev.
Yeah, welcome. We are on time.
Yeah.
We just started.
Thank you. Right.
I think at the onset, I would like to introduce Dr. Jyotidev sir. He doesn't need any introduction, but it is customary to introduce the innovator of diabetes management in Kerala. So everybody knows about Dr. Jyotidev Keshav. He had his MD and MBBS from Government Medical College Trivandrum. He also had endocrinology fellowship training at the Mayo Clinic, USA, and FRCP from London, Glasgow, and Edinburgh. He is the chairman of Jodev's Diabetes Research Centers, which is mainly based at Trivandrum. It also has branches at Kochi and Attingen. And he's also the managing trustee of P. Keshav Trust, which is engaged in charity and literary activities. And he's also the vice president of AIAARO Kerala chapter, which deals with diabetes and obesity. And he also conducts monthly diabetes education classes via YouTube channels. And he serves in the editorial board of multiple diabetes journals. And he also publishes a monthly internet-based free diabetes newsletter, which has been there for the past 12 years. And he's also the first author for Indian guidelines on vaccination. We saw his interest in vaccination with the previous lecture, and also on insulin pumps and glucose monitoring. And he's also a pioneer in cost-effective treatment of diabetes with use of telemedicine and technology. And he has lectured in more than 500 forums within India and in more than 20 countries. And Jodev's Diabetes Center is an IDF-recognized Center of Excellence in Diabetes Care and Center of Education. And also, it is accredited for RSSA certificate course in diabetology for doctors. And it's also the Center of Excellence for Medtronic and Roche for technologies in diabetes. And Jodev's Diabetes Center has completed more than 580 diabetes screening, detection, and education camps across Kerala. So over to you, Jyotidev sir, for your introductory remarks.
Yeah, thank you, Prashant. This is a first of a series of programs, and this we have named it as 100 years to the discovery of insulin. So all of you are aware of the fact that we'll be commemorating 100 years of discovery of insulin within another couple of months. And we thought that JPEF should be initiating a very special event discussing the current scenario, the evolution of the newer insulins, and why the use of insulin, similar to the vaccination that we have discussed, why the use of insulin is still less in many parts of the country, and why in the absence of use of insulin, patients are developing more and more complications. So in the next 20 to 25 minutes, all the four of us, along with the panel, we'll be discussing some of these aspects of insulin. And the topic today will be advances with the molecule and advances with the delivery devices. So let me go to Dr. Ashwin David for his introductory remarks. Ashwin, sound, volume. You're not audible.
Okay, am I audible?
Now audible. Yeah, please.
Thank you for the introductory remarks. So now I would like to introduce the second panelist, who is none other than Dr. Arunas Menon, sir. He is the head of the department and senior consultant endocrinologist, Lisi Hospital, Kochi. He was working as a professor of endocrinology in Amrita Institute and Medical Science Coaching. He has very wide interest in topics and a special interest in topics like microvascular complication, diabetes, diabetes management of obesity, osteoporosis, and thyroid disease. He is the secretary of Indian Thyroid Society and the past secretary of Kerala Endocrine Society. Welcome, Arunas Menon, sir. And during the next sometime, 5 minutes, we will be hearing from Dr. Prashant Shankar, the 100 years of insulin, a quick peek of the centenary cruise. So over to Dr. Prashant Shankar.
Thank you, Dr. Akshay. So I'll be just having a brief run through what has happened in the management of diabetes over the years and how we have developed or reached this stage of diabetes management with insulin. So 100 years of journey of insulin, a quick peek at the centenarian cruise. So walk with me. So we will cruise through 1,000 years before 1921. Why this discovery is memorable in the history of diabetes, and also we will see 100 years after 1921, and then we will discuss an era after 2021. What are the innovations we are expecting with insulin? So these are the 1,000 years before the 20th century. In the second century itself, we had evidences of diabetes. Idiaceus of Cappadocia provided the first accurate description of diabetes, coining the term diabetes. And in the 17th century itself, the term mellitus was used to describe extremely sweet taste of urine. In 19th century, Claude Bernard and the discovery of the glycogenic action of liver was described. Minkowski and Joseph von Mering recognized that diabetes is a disease of the pancreas when they showed that a dog with pancreas removed showed symptoms of diabetes. And Frederick Banting, Charles Best, and John MacLeod showed the fruits of progress in insulin discovery. This is probably the most controversial picture we are talking about in the last 2 days. So a surgeon, the Ayurvedic surgeon performing a surgery. But I just put it on two contexts. We just wanted to tell that Sushruta in the 6th century BC noticed the sweet nature of urine in patients and termed the coin Madhumeha. So India also has got a rich tradition when it comes to diabetes. And this is the pre-insulin era where diabetes was known as the kissing evil. So before the discovery of insulin in 1921, the chance of death for a child diagnosed with type 1 diabetes was 100%. So coining or designating a patient with diabetes meant that the patient would definitely die because of diabetes. There was no treatment for diabetes other than restricting the carbohydrates. Then in the early 1890s, came the role of Minkowski and Joseph von Mering. As I said, they observed that dogs who had a pancreatectomy developed diabetes, and they finally confirmed the central role of pancreas in the etiopathogenesis of diabetes. And then started the evidence-based medicine and the discoveries which led to the discovery of insulin. So which provided hope for the first time to all those people suffering from this debilitating disease. And this is how the newspaper looked in 1922, Toronto doctors on track for diabetes cure. And 100 years after 1921, how we have progressed. This is Leonard Thompson, the first person who was given the insulin molecule. And you can see how the kid changed from that cachectic species to the healthy child. You can see on the left side. And these are the scientists who are behind the fantastic behind the insulin delivery. And then we had a series of innovations and discoveries which led to the current insulin. From 1920s, the early syringes were discovered. Then we had in the 1930s the X-ray photograph of insulin, and in the 1940s we had the NPS insulin, which was there. And by 1973, the purest insulin was came into the market. And then in the 1980s, the first human insulin was launched in 1989. It was Novo Nordisk who marketed Novalis, which is the first pre-filled insulin syringe. And in 1999, Novo Rapid, the analog insulin, came into the market. Sanofi came with Glargine, the first basal analog insulin in 2000. And then came in 2001 to 2004, the analog insulins like Novorapid Pen and the Livomir, which is again the basal insulin. And in 2010, Novopen Echo was launched. So the newer generation insulins marking the milestones. 2013, we had Tresiba, which is the ultra long-acting basal insulin, and Rizodex, which is the co-formulation of Tresiba and Aspart, and Fiasp, which is the ultra fast-acting insulin, which came into the market in 2018. So the evolution of insulins and insulin regimens only to make it more safer and acceptable. So over 90 years of continuous research, development of highly effective insulins with safer profiles have been there. It's not that the insulins previously were not effective. Even the conventional insulins we are using today are effective, but the change has come because of the safety aspect and the flexibility and the patient friendliness. That's where the newer insulins have their advantages over the conventional insulin. And the perception that insulin therapy is complex, less safe, and that makes life inflexible, that has to be changed. That has been changed with the advent of the newer insulin. And innovations in basal, bolus, as well as premix insulin and the co-formulations have made insulin therapy much safer. It has become much flexible and patient-centered and patient-friendly. And it has become so simple and pragmatic. And we have the Indian guidelines, which are based or customized to the Indian people with various types of insulin formulations which can be used for initiation and continuation of insulin therapy. So with this introduction, we will move into the panel discussion on bridging barriers to insulin use in diabetes. I think I will start the first question with Dr. Jyotidev, sir. So, sir, shall I start with the question?
Yeah, we can. Yeah, please proceed.
Yeah. So the question is regarding bridging the barriers. We all know that even though it's 100 years of insulin use, there is still that barrier which persists. So insulin has stood the test of time to be the anti-diabetic agent with unmatched glycemic efficacy, but the adoption by physicians and patients is suboptimal in India. And what do you think are the common challenges faced by a general physician or a primary practitioner in adopting insulin therapy, and your suggestions to overcome this?
In fact, to discuss about this and to answer to these questions, we will require at least one full day. Because I remember Ashwin telling me that Ashwin is practicing in one of our centers in Attingal. He is heading that center, and there he found that there is a very high level of reluctance from the part of the patients to accept insulin. And when compared to the center where he has worked earlier, that is our center in Trivandrum, the prevalence of retinopathy and other complications were much higher. And he was telling me that the average A1C is also around 12 to 13 there. So it depends upon the geographical location. And for those doctors listening to this conversation, in one of the advisory board meetings in India, we were presented with the statistics on the use of insulin in India. And Kerala is one of those areas where there is a very high level of insulin use. Thanks to probably the educational status of our patients. So that makes a difference. So basic difference is when we are trying to convince the patient on the need of insulin, we need to discuss based on their level of awareness. So first we need to assess initially the level of understanding of the patient and start with what happens in type 1 diabetes, what happens in type 2 diabetes, because I have seen even patients with type 1 diabetes who request to stop insulin. Almost all of you could have seen. And when you look at the history of insulin, there is one slide saying that before the discovery of insulin, 100% of the patients with type 1 diabetes used to die. So that used to be a death parent for them, the diagnosis of type 1 diabetes itself, before the diagnosis, before the discovery of insulin. But in type 2 diabetes, we should be successful in convincing our patients of the relative insulin deficiency. And if you look at the studies conducted from various parts of the world, it's the patients who are at a higher A1C who will be more reluctant to start insulin. That is quite surprising. And those who are having a relatively low A1C, such as 7 or 7.5, when we try to initiate insulin, it is fairly easy because they are more motivated and they are the ones who reach the doctor sufficiently early. And there is something called clinical myopia. This is a phenomenon where the doctor and the patient is bothered only about the next day or the next week. And that is a short-sightedness. Whereas when treating diabetes, we as doctors and our patients should be taught about the long-term consequences and complications and the need of prevention of those complications. So this long sight is actually lacking for the community. And when you look at the ease of starting insulin, it may be quite easy for most of the doctors like this, because iron will be 100% successful in starting insulin. Whereas a general practitioner or a physician practicing diabetes among many other specialties will find it difficult. And the solution will be the same solution which is recommended by the International Diabetes Federation this year. Diabetes nurses makes the difference for diabetes, because there should be nurses and diabetes educators working along with the doctors who will be spending more time training, teaching, and troubleshooting. This training, teaching, and troubleshooting are three different. Because once started, studies have shown that even in the specialty clinics, when we are successful in starting insulin, it is rarely intensified, and hence the A1C will remain there. And I think the last challenge, and probably the major challenge starting insulin for the common doctor and the doctors in allied specialties, because all the neurologists, nephrologists, cardiologists, all of them are forced to practice diabetes now, including the gynecologists in our community. They are all forced to treat because patients want them to treat their diabetes. And the challenge will be hypoglycemia. So when Prashant is presenting the generations of insulins, I would say that the best thing that has happened with innovations, when we travel from the human insulin to the analog insulin to the best analog insulins of the current year or the current term, the best thing that has happened is with every generation of the analog insulin, there is a substantial reduction in the hypoglycemia. So the only solution is education, education, education. And that's what we are doing. And our doctors, our colleagues in all the specialties need to be continuously trained and educated on the ease of using insulin, especially the urgent need during this pandemic.
Thank you, sir. I think that was the optimal answer which had to be given. Again, stressing on the importance of a diabetes educator. Even I face this problem. Whenever I start a patient on insulin, the diabetes educator gets at least 10 calls in the next 2 days. Because the patient has a lot of concerns which we may not be able to discuss in the OPD. And the patient has to spend more and more time with the diabetes educator to get that confidence of using insulin. And as you rightly said about up-titrating the insulin. The titration part is something which is forgot. The patient may initiate it, but he may be worried to up-titrate it. The next question the patient asks after starting insulin is, when can I stop it? So the up-titration part is something which has to be again discussed with the patient, and in multiple sessions, the patient has to gain the confidence.
Thank you, Dr.
So,
Yeah, thank you. Thank you so much. Thank you, Jodhir sir, for answering the first question in a very crisp and very informative way. Actually, sir has very rightly pointed out and clearly shown over the years that it's the education and the teamwork that is the most important thing that has been able to take out the inertia from the era of inertia can be taken out. So now let's discuss on the second part, the latest innovation that has been there in insulin, and what are the treatment success which can be, or how the treatment success can be achieved, and how the inertia can be broken out. So as we all know, the best way to treat with insulin is to mimic the physiological pancreatic secretion. So my question is to Dr. Arun Menon, sir. So what are the recent advances in insulin therapy that has been shown to mimic the physiological pancreatic secretion in terms of basal bolus, premix, and co-formulation therapy? Over to Arun Menon, sir.
Thank you, Dr. David. Am I audible?
Yes, sir.
I am, I presume. Okay, thank you. Yes, I think, I would like to emphasize once again what Jyotidev has said. I think he has really given all the important issues that we are facing as a country, the reality that India is facing. Basically, all these issues, that is, to start off with, it is the high carbohydrate load that we take. We know that's a big problem in itself. And that leads to that high postprandial contribution, again, something which we all know has been the biggest problem. Although there have been huge advances in the number of OHAs that have come out in the last decade or so, there is still that situation where we know time has run out in terms of the OHAs and the lack of control on OHAs. And as Jyotidev touched upon, it's a clinical inertia that is the biggest problem. So we change from one to another, from one sulfonylurea to another, from one metformin to another. People do all sorts of things. It is just because, as you said, it's that myopia, or I think was it Prasant or Jyotidev who said, so it's that myopic vision in terms of, so what do you want? What many physicians want is, oh, I just need to just keep this patient somehow controlled. I don't have time to spend to convince them. Of course, we'll talk about insulin and they will say, oh, not this time, doctor, next time. And then you have to, where you're going. You just have to spend a lot of time with these patients. And one of the problems that I've seen with as Joseph said, Kerala is way ahead, far ahead. However, the problem in Kerala is that to convince patients, you need to give them all the right information. So unlike in some other states where the doctor says, and that's a word, and if the doctor says, no, this is the treatment for you, you're going to have it. I'm not saying everybody does, but a large proportion might, or a bigger proportion might take that advice. Here, they will not take that advice unless you convince them as to the reason for this. Now, this is where many a times probably the bigger hospitals, although we would be able to convince them more, because in a way, a chosen patient, the patient group who comes to us in a tertiary center are a select group, because they know what we are going to say. They are coming for that sort of treatment. So it is, in a way, the patient groups that we see in tertiary hospitals or big hospitals are patients who have already said no to physicians who have tried their best. They know what they are coming in for. And when you say, then they kind of know, once you start to say, that they've heard this before about insulin, and that is what they need. Unfortunately, the private hospitals, most private hospitals, although even that trend is changing, doesn't invest enough on education of patients. So whether that be getting good quality educators, more importantly, as Jyotidev was saying, training your own staff. The number of, even now, even in most wards, they chase the sugars, isn't it? As an inpatient, what you see is, it is always chasing the sugars, and you have to hit your head against a brick wall. So what happens? The sugar is high, they will give a big dose of insulin. The next is a hypo, so they skip the next dose of insulin. And then they'll say this patient is not in control. And you ask, what do they? Oh, they got a 26 in the morning. And afternoon, why did you not give? Oh, afternoon, it was 120. I said, that's normal, isn't it? Yeah, but we are afraid that it might go down. So that's it. So this sort of simple messages have not even reached the health professionals, leave alone the patients. So there's a huge challenge in terms of educating our nurses, as we were saying, our other medical personnel. And that is when we can move forward with insulin. But I think when we talk about the innovations, I think it's important that we keep that within that Indian reality, that we have a long way to go to even convince the patients and then move on to this type of insulins. So in this sort of scenario where there is a high carbohydrate load, high postprandial sugars, you want insulins that will give you the best results. What do I mean by best results? Of course, we need a good control, okay, and that is number one. But we don't want hypos. Again, has been said earlier. We want to keep the dose to the minimum, and we want to encourage patients to monitor, because the number of patients who actually have been on insulin for 10 years who don't have a glucometer itself is a startling figure, and they look at it and look at you as if, I'm sure they have heard that before, but when you say glucometer, they say, no, I've got a lab just next door. That's not the issue. It's not a question of whether they have a lab there and they can do sugars once in a month. The fact that they are not involved in their diabetes care is very amply shown by the fact that they don't possess a glucometer, or they don't think it is important to possess a glucometer. So again, it all boils down to education. But in all these, having these newer analog insulins help, because as we have already said, the hypos are less, they are much more effective in controlling it. What is the only barrier for that is only the cost. I mean, if the cost was not an issue, we would have started these insulins way ahead. And where does these insulins help? If you take the case of rapid acting, which is the insulin aspart and the Humalog and Humalog Lispro and the Apidra and all that. So all these rapid acting insulins, or the most recent one, which is the FIASP, which is the ultra fast acting, ultra rapid acting insulin, where you have even more flexibility, because these patients can take the insulin even after they have eaten. And there are wonderful studies even comparing these two, even the rapid acting versus the faster rapid acting or fast acting rapid, and actually showing that they're even better than the rapid acting. So this gives you even more flexibility. The cost is not an issue because they are pretty much of the same cost. So if patients can afford it, then there is nothing better than this, because the hypos will be significantly reduced, and that will be a big bonus to the treatment. And then the flexibility, okay, with this rapid acting insulin. So we are talking about analog insulins, which is physiologically mimicking the insulin release from the pancreas during eating, and that is the best insulins we have now. I'm sure there'll be more innovations, hopefully, but even now, I think if you are involved and ready to use these insulins, you can get excellent results with this insulin itself. So that is the rapid acting insulin. Now, what about the basal insulins? We didn't touch upon that. Again, I think Prashant had said about the glargine and the degludec and the detimir and all that. But again, this glargine and the newer glargine, which is the 2-GO, and more importantly, degludec, they all have excellent results in terms of lack of hypos, I think, and the flexibility. The fact that even if your timing of injection changes a little bit, they don't, the blood glucose levels don't vary. So you might, a busy professional might forget to take it in the evening at 10 o'clock, or if you put it as 8, it might be 10 by the time they come. They can take it at the time. A few hours here and there will not make a difference. And that flexibility is a huge bonus again for many patients. So we now have analog insulins, whether that be rapid acting, ultra rapid acting, or basal insulins, which are ultra long acting. They all have features of less hypos, more flexibility, and they will surely, if used rightly, and that is where, again, that is the question mark for us. It is the education of our own staff, our own educators, and we have to spend time with the patients, convince them. And I think Kerala, if we are able to spend time and give them that deal, I'm sure many more patients will take it, and that is probably the best thing we can do for them. So I'll stop there. Sorry if I have overrun my time.
Thank you, Arun sir. Thank you, Arun sir, for that important message which you have provided, the importance of the team and importance of the newer innovations that are shown to be beneficial in reducing hypoglycemia, especially the nocturnal hyperglycemia and the flexibility. Thank you, sir. Over to Dr. Prashant for the next question.
Yeah, I will quickly move on to the next question. We have talked about the innovations in insulin, but insulin has to go inside. So then comes the next barrier, the injection. So I'll go to Jyotidev sir directly about the innovations in insulin delivery devices. There is none other than Jyotidev sir who can explain on the innovations. He's a master on that topic. Sir, your thoughts on the advances in insulin delivery devices, and how are they able to bridge the barriers of treatment?
Yeah, Prashant has initially pointed out the launch of a Novo syringe. So that was a landmark device, and that was in 1925. And that was the first one after the BD insulin syringe. And then we witnessed the launch of Novopen. And Novopen was in 1985, the first Novopen. And then came Novopen 2, Novopen 3, Novopen 4, and now we are using Novopen 4. So this is the Novopen 4. So can you stop sharing the desktop?
sorry.
I think, yeah. Thank you,
Somebody
Dr.
done it?
Aaron. Yeah.
Thanks.
So this is the Novopen, and this everybody is familiar with the Novopen 4, and this is the most popular device for. This is not disposable. This is a durable pen. You can use the pen filled cartridge again and again and again. But the advancement which has happened with this delivery device is the ease of use, and there is a click over there, and even if there is some impairment in vision, the elderly can use it because they can listen to the click and then count the number of units. And this is fairly easy to push because it is soft touch. And then I have, then you spoke about the Novo LED, and I still remember the Novo LED from Mixta Novo LED, the Actrapid Novo LED, and those were there for more than 10 years. And 10 years ago, we saw the launch of the Flex pens, and now it is a Flex Touch. And we have several pre-filled pens available in the Flex Touch design. So this is the one that Dr. Iron was describing, the Fias Flex Touch. And Fias, I believe, is a phenomenal improvement in the rapid-acting insulin, because this can be given just before food, very rapid in action, two-fold higher insulin action in the first 30 minutes after the injection. So that is a rapid onset of action, and there is a rapid offset of action. So that translates to more time in range and less time below range. So there's less of hypoglycemia. And the same Flex Touch is available for Degludec. And this is one of the, I would say this is the best basal insulin currently available in the market. And this is the co-formulation, because I'm very much fond of this co-formulation, especially during this COVID. Why this pen is so special. So I will show you one of those slides where let me pick up a slide from here. So if you look at these designs of this Flex Touch, this is the only pre-filled insulin pen with no push button extension. So there is no push button extension here. And that is very, very unique. And the mechanism of action is so friendly for even the elderly, with dexterity, with Parkinsonism, with tremors, because of the very low dose force. And there is an end of click. There is the end of dose click, so that it alerts the patient that that is the end of the injection, so that they can have this remain under the skin for another 10 to 20 seconds before withdrawing the needle. And there is a consistent accuracy in the dosing. And these pens are designed for accuracy and for ease of use. And there is one more pen currently not available in India, but this is something which I am very fond of, and this is a Novopen Echo. Novopen Echo was launched, I believe it was launched 10 years ago. And this is currently not available, not 10 years ago, 19 years ago. But Echo is not available in India. This is meant for pediatrics in children. And this has got a memory. I will show you the memory. It will show you the last dose and also the size of the last given dose. And this has got a battery life of 5 years and with 800 memory. And the next gen pen is Novopen Echo Plus and Novopen 6, and both of them are near field communication enabled. They are all NFC enabled, so that they can communicate with the app in the phone. If the phone is NFC enabled, so that it can communicate with either MySugar or Diascend, and this can indirectly automate the delivery of insulin. So even for those patients who are on Degludec, those patients who are on Fias, they will get recommendations on insulin dosing with the data which is drawn from the insulin pen and from the continuous glucose monitoring devices. And the algorithm in your mobile phone will recommend the dosages. So the NovoPen, already Novo Nordisk has got their collaborators such as Medtronic, Abbott, all of them are CGM device manufacturers, and these all will connect with the pens. And that will be the era. So that will start from next year onwards, and that these are the connected insulin pens. And why these devices are important, especially during the COVID pandemic. Dr. Irenas Menon was discussing about the importance of starting insulin. So if, for example, if I have started Degludec as a basal insulin, because I make sure, because all of those who are working with me, they all know that we start insulin very early in our patients, very, very early in our patients. And that is when the A1C is normal and when the duration of diabetes is beyond, say, 7 years or 8 years. And during this pandemic, actually, we were very safe. The telemedicine guidelines were recommending use of insulin only in those who are already on insulin, and we cannot initiate insulin afresh during the telemedicine consultation. But majority of our patients were already on some insulin or the other. And hence, for us to initiate a rapid-acting insulin, it was quite easy, because if the patient is already on a basal insulin, then we can start a rapid-acting over the telemedicine consultation, because they are already taught about the use of insulin. And for insulin such as Rysodex, because I just saw a question about the cost of insulin, because for Rysodex, there is a 30% reduction in the cost. And if I am starting this as a co-formulation where there is both Degludec as a basal insulin and Aspart as a rapid-acting insulin, then I can start this as a once daily insulin, and then if a need arises, I can make it twice daily. So it is much more flexible and at a lower cost. And the question on why should we have all these newer insulins? And I will again go by what Dr. Prashant, Dr. Ashwin David, and of course, Dr. Arun was describing detail on the necessity of diabetes educators, nurses, and the supporting staff. The take-home message will be, there are two choices. One is we can, of course, implement a preventive management diabetes, a proactive management, using vaccinations and using insulins fairly early. And that is a cost-effective methodology of managing diabetes, using better preparations. And the second choice will be, you can treat diabetes more aggressively with insulin at the onset of complications such as retinopathy, neuropathy, or coronary artery disease, or with a very high A1C when all the oral drugs have failed. And the second is a scenario when the quality of life is already gone. So the patients and we can decide on whether the quality of life need to be retained or not. If you are starting insulin late, after all these complications have set in, you are probably not going to help him. You are only trying for a palliative management in diabetes. So let us be early in initiating and intensifying insulin. And of course, we go by the statements made by Dr. Arun on having a support team along with us. Because in the absence of a supporting team, it will be very difficult to troubleshoot, because most of the patients are highly educated patients. And I just got the information from Deepu that more than 502 doctors are with us in this evening. And most of them, I believe, are practicing diabetes, and more than 50% of the registrations are from many other allied specialties. But make sure that we are training our patients adequately. But more important than starting insulin will be intensifying the dose of insulin and preventing hyperglycemia. Because the idea, the objective is only to help our patients retain their quality of life. We are not treating the complications. We are trying to prevent the complications.
Yes, sir. That's the exact message which we want to give to the both to the practitioners and to the patient. So insulin is not a drug which is started at the onset of complication. The main aim of managing diabetes by any clinician is to prevent the complications and to provide the patient good quality of life. Thank you, sir, for that wonderful explanation. Over to Ashwin.
Thank you, sir. Thank you, sir, for the very good explanation. Without wasting my time, and as we are running short of time, I'm going to have one more last question. I think this is one of the most important questions which we have to put in. The question is, sir, as we all know that this is to Arun Menon, sir. We all know that there are a lot of medications available, drugs available, but there are some special situation or special population of patients where insulin should not be missed. So, can you please enlighten us with what are the special situations in which the insulin should not be missed, and what are the insulins that can be used in these special situations? Over to Armin, sir.
Yeah, thank you, Dr. David. I'll try and be very short and to the point because I think time is an issue. I mean, we know about some of the special situations. I'm just going to touch upon one or two, only one or two of them, but we'll quickly say. But we know pregnancy, whether, I mean, type 1, there is no question. We know they will be on insulin, so that is fine. So they're on insulin. But what about gestational diabetes? It is one of those situations where it is very important to consider insulin at the right time. Now, not being critical of anyone, but what we see is quite a lot of patients are started on a small dose of insulin in the beginning and then left without checking often. And that is one of the biggest problems we see in a gestational diabetes scenario many times. And that, educate. So what should go into that is intense education of the patient, and they need to understand how their glucose levels are going to work, or how their glucose levels are going to behave, I mean, during a pregnancy and when the pregnancy progresses. And the insulin should be tailored to their glucose profile. Now, what happens is it's very often, I'm sure my colleagues on the panel will all agree with me, or at least they will have their own views on this. But we see so many people who are just put on a small dose of Mixtard in the morning. That's it. So it's as if, yes, we need to give some insulin to patients with gestational diabetes. Let us give 6 units of Mixtard to this patient in the morning. Now, that to me is not applying science. That is just applying the theory that, yes, I have given insulin. That's all that matters. See,
I don't know. This is a very important issue that you are speaking, because in gestational diabetes and pregnancy and diabetes, actually our ladies, our patients are not getting the adequate treatment. Either they are in hyperglycemia or they are in hypoglycemia.
Yeah. No,
because I remember Dr. Sheshaya making a comment, when you're treating GDM properly, you are saving the next generation.
Absolutely. Absolutely. Yeah, absolutely. And I think, Joseph, I think the biggest problem is that I still see patients who have been on insulin for a few months during GDM or pregnancy. They don't have any understanding of how their glucose is behaving, or what this insulin is supposed to do. It is like just they are on insulin because they are supposed to be on insulin. See, that's not the question, isn't it? They managed their diet accordingly? Have they managed their exercise accordingly? Do they know, is it the fasting that's going up? Is it a postprandial abnormality? Which time? So you ask these questions and they look at you as if you are, what is wrong with this guy? Is he trying to? So unless you understand this, you're really not going to make a difference to the, as you said, the next generation, because your baby would still be born big and all the complications will be more. So you can use the best insulin, but unless you understand what the patient's profile is, and unless you don't tailor that. So there are so many patients who all they might need is just two Novarapids or 2 Actrapids, because that might be where the problem is. There might be some patients, all they might need is just a basal insulin for a period of time. But as you know, it rapidly changes over time. So unless we involve a lot more. So I think we unless this concept gets into our colleagues as well, I understand that many patients don't, one of the problems with pregnant women, they can't wait in OPs, they can't wait to see an obstetrician, then they come and wait in a front of a physician for another couple of hours, and then it's just, so it's a practicality. This is where more and more combined clinics should come in. And combined clinics where it's not just a question of sitting together and chat. It is a question of making sure that what needs to be applied is applied, and the knowledge of both the obstetrician as well as the physician as well as endocrinologist if required, whoever that be, they are all together in that decision making. I think that's what should happen in these scenarios. So I can always talk about this insulins. Yes, there's all these insulins are safe. If you look at data, there's data for almost everything. The degludec is safe. Glargine is safe, although the license is not there for glargine. There are a lot of patients who are already on glargine for whom we continue to use it. But all the other insulins, this thing, you can use it. Many a times you might get away with the traditional insulins, but if they are not, see, this is why. So this, just sticking them on a mixed start is not enough, because they might do really well on one of the analog insulins that we have. And you can see remarkable. There are ways of finding this out now. With in the era of CGMS and all, you should not spare efforts to really understand that profile and use the right insulins. And that is where I'm very confident that if you start to use analog insulins more and more, you will see the difference. And you should know this by yourself. It's not because I am telling you or Jodev is telling you. I think every physician, it's not rocket science. We all know this. Diabetes is not rocket science. Anybody can do this, but they just need to get involved, and they should have a team to support. And then look at the profile, and then it's common sense. Even your patient will tell you, see, okay, this insulin is working better than the other one. So I think we have to start to use this insulin. So analog insulins are brilliant in a GDM situation, and we should continue to use that more and more. So that is one of the situations. Now, because of time, lack of time, I'll just very quickly move on. The other situation, CKD, and even I would say CLD into this, but CKD is what we have just talked about. That's what David had asked me about. But CKD is a very, very difficult scenario. We know this again. Now, what happens many a times when these patients have CKD, their diabetes treatment gets neglected. That is again because these patients spend hours in nephrology, hours in dialysis, hours in. So all those things take priority. And the last thing in there, this thing is the sugar control. And if you ask them about sugar, they'll say, I don't care, something is happening. So they'll say my sugar is going down or going up or whatever. And you feel, you're as if you're apologetic sitting there and you say, okay, that's more important. Okay, you go and treat that creatinine or But unfortunately, if you're letting the quality of life is affected, Jose was talking about this, the patient is not confident of managing their insulin in that scenario, because we know it is going to highly fluctuate at that time. They're going to have hypos where they don't have awareness. They're going to have hypos which will make them less confident of managing their diabetes. And at that time, we still have wonderful insulins that we can use. And we just stick them on a small dose of actrapid, and we tell them, oh, if you have hypo, don't take it. If you're hyper, you just take it. So that is not the thing. There is science behind this. There are all these insulins have got evidence to support that they are much better than the human insulins. They last in the system shorter. Even in CKD scenarios, they give you fairly excellent profiles. As this would again, this is about the basal insulins, and that was about the first slide was about the rapid acting insulins. This was about the basal insulins. There are a lot of studies in all stages of end-stage renal disease, which have shown that these are safe. Not only safe, they are much better, much smoother profile, and you have to start to use these insulins in these patients. Otherwise, I think we are doing a huge disfavor to our patients. So see the studies. I mean, again, I'm not going to go into it in detail, but the kind of profiles you can get in CKD patients. Now, this is not, it's nobody's just drawing this up. It is from studies. So you have insulins. See that for yourself. What is the problem in using this? We know that many renal failure patients, but not everybody, many renal patients need small dose of insulin. All they need is small doses. Give them the best insulin. Cost is not an issue there. Cost is not, that is not the thing that is going to be costly. The dialysis and all the things that is going along with it is what is really, really costly. If they get an infection, that is curtains for them. So even if you can say, prevent one infection of whatever, because of a much better control, if you can prevent an admission due to a severe hypo, that cost saving is much more than any insulin you would use during the entire time of their dialysis period, isn't it? Or transplant period or whatever. So I think that is my message. Don't think about the cost when it comes to CKD patients, because by saving even one hypo admission in this patient, you have done them a huge favor. They have saved a lot more money than they would ever imagine with this insulin. So don't hesitate in this situation, at least. CLD as well. I would say even CLD I would include in this. I'll stop there and then,
Thank you, Arun sir. Arun sir has clearly explained what are the special situations, because these situations we should never ever miss the importance of insulin, because we should not miss insulin in these, especially in CKD, especially in GDM, and one most important thing is the CLD. And sir and Jyoti sir has clearly showed the importance of self-monitoring of blood glucose in all these situations for a better titration. Thank you, sir. Thank you so much. Over to Dr. Prashant Shankar for the concluding remarks.
Thank you, Dr. Arun sir and Jyotidev sir for that wonderful discussion. As Jyotidev sir mentioned in the beginning, you can talk hours and hours and days about the advantages and the disadvantages of the newer devices and all those things. But in the limited time which we have had, I think it was a crystal clear discussion on the topics which we discussed about the barriers to insulin injection, barriers of initiating insulin injection, the barriers to use of the devices, the advantages of using the devices, and Arun sir spoke so well about the problems with in-hospital patients who are being managed with insulin, and also on gestational diabetes, which is again a very important area, and patients with CKD and CLD, again, who require insulin for their proper management. And the final aim is keeping the patient in center and managing the patient as a team. And the patient is there in the center of the team. And we as physicians, along with our healthcare team, the nurses, the diabetes educator, the food care specialists, the nutritionists, all have to work together to provide the best possible treatment to the patient. So thank you once again for this wonderful panel discussion. Over to the organizers. Thank you again for giving me another opportunity. Thank you.
Thank you so much. Thank you all the panelists and moderators. It was a very healthy discussion. Without further ado, we are moving on to the next session. To chair the session, I would like to invite Dr. Mohanty Shenoy, Consultant Endocrinologist, GG Hospital, Trivandrum, and Sri Gokula Medical College and Research Foundation, Venyaramudu, Trivandrum. Over to you, sir.
Yeah, thank you. Thank you, everybody. Thank you, Jyotidev sir. Thank you, IMA Neema, for giving me the opportunity. And I find my teacher also in the crowd, Dr. Arun Menon sir. Welcome. I heard your lecture in detail. Thank you for the discussion. So, friends, we are in the Diabetic Awareness Month, or World Diabetes Awareness Month. So, JPEF Mini CME Virtual on focusing on 100 years to insulin. So my topic of this next half an hour, Dr. Jyotidev sir, Gopika, and myself, I think we'll have a panel discussion. So the topic would be on demystifying the glucose terminologies in glucose monitoring. So when this topic came into our view, the first thing we wanted it to be very inclusive of the basics. So as we know, IMA Neman branch is organizing this along with Jyotidev sir. So we want to make it very simple and which is very endearing for all the people who are listening to this. So diabetes was recognized as far back as 1500 before BC, that is before Christ, and by the Egyptian scientists. Did you know that initially period, they were actually diagnosing by ants drawing towards the urine with people with diabetes. From that time, we are now progressing fast and we are gone into the era of molecular biology as well as sensor-based technology. And we have to really welcome technology, but we should know what all are the new terminologies in technology as well. So, so the first monitoring was done by urine glucose values, urine sugar values. The urine was measured and was found to have glucose value initially by tasting it. So that was the first way in which they used to monitor it. So for the first panelist for this is Mrs. Gopika. So the question for this, I will introduce. I think we should introduce the panelist. Dr. Jyotidev sir doesn't require much introduction. We all know he's the chairman and director, and he's a managing trustee of PJ Keshav Trust. He's the vice president of IRACON.
I have been introduced. A while ago.
Okay, sorry, sir. Sorry, sir. Yeah. Gopika Krishnan. He's academic head of JD Research Center. He's alumni of College of Pharmaceutical Science and Government Medical College, Trivandrum. She's also a lead coordinator of more than 10 multicentric clinical trials. He's a clinical pharmacist in multidisciplinary diabetes team care involved in patient care. She is having a lot of laurels. I have been seeing her in the limelight, and her husband is also my close friend, Vinu, and he has presented in many papers in international and national forum. So I welcome both of you to this lecture series in the panel discussion. So as I had mentioned you, both of you, so we have already gone from the generation where we had the urine glucose, urine sugar testing from the latest, which is the sensor technology. In between, we also have the self-monitored blood glucose, as well as we have other devices as well. So the first question to the panelist, Gopika, would be, what is your opinion and what is the take regarding urine glucose testing, urine sugar testing, and how is it now? Is it really important now, and why is it obsolete now? What are the limitations to it?
Okay. So thank you, Mohan Tishinoy, sir, for that kind introduction. And as rightly mentioned by you, attempts to monitor glucose in the urine dates back to almost 1800s. And a major development happened when Benedict's test was introduced. And we used to have Benedict's test for more than 50 years until in 1965, the AIMS developed the first glucose test strip. And later in 1987, the American Diabetes Association established the SMBG guidelines. The major limitations of urine glucose testing is that the normal renal, the so-called normal renal threshold for glucose is 180 milligram. But we are very much aware that for many of the diabetes patients, this threshold can vary. It can vary from 50 until 300 milligram per deciliter. So many of the patients may fail in the urine glucose estimation. So glucose-urea may not be there in many of these patients. Another major limitation is that it does not show the low blood glucose values, and yet another limitation is that the urine glucose value is a qualitative estimation. So the color changes, subtle color changes, are difficult to interpret, and many of the drugs such as vitamin C, iron supplementation, levodopa, etc., all these have been found to interfere with the urine glucose testing. And moreover, with the advent of the SGLT2 inhibitors, if you see over the past 10 years, for those patients who are on empagliflozin, dapagliflozin, or canagliflozin, for all these patients who are on these drugs, there'll be glucose in their urine. So this can actually affect, this can give false negatives or false positives. So this is one of the major limitation of urine glucose monitoring, and why this test has become obsolete. And it also does not give the blood sugar reading at a particular point of time. It gives the readings over the past several hours, so that cannot be used for titration, especially the titration of insulin, other OHs, etc. So I think those are the major limitations of urine glucose testing and why it is obsolete now.
Yeah, so sum it up. So it's having an interpersonal variation. There are confounding factors as well as the newer medications which are playing a very important role, because we cannot measure urine glucose for the SGLT2. Okay. So furthermore, we also heard about the fasting glucose. So we also know the postprandial glucose. So by definition, they have got various criteria and various organizations giving various thresholds. Also, there is a controversy debate regarding 1 hour value of PPG versus 2 hour PPG. Can you throw more highlight, Gopika, on this as well?
Yes. So if we go by the American Diabetes Association recommendations, fasting is no caloric intake for at least 8 hours. So when doing a fasting blood glucose test, this is the test to be done first in the morning, and a plasma glucose after an overnight fast of at least 8 hours is what is called the fasting glucose value. And the criteria for diagnosis of diabetes is a value of more than or equal to 126 milligram per deciliter. So this is the recommendation.
There is a consensus by all the almost.
And if there is an absence of unequivocal hyperglycemia, then you need to, the diagnosis can be made only after 2 consecutive tests taken from the same test sample or from 2 different test samples. And
what about postprandial glucose?
Postprandial glucose is, postprandial means it is after a meal. So 2 hour postprandial glucose is what is recommended by ADA, because that gives you the peak value for a diabetes patient, because as we know, in type 2 diabetes patients, there is abnormalities in the insulin and the glucagon secretion. So if you want to assess the postprandial hyperglycemia, it is best to go by the 2 hour postprandial value. So, and the 2 hour postprandial value, if done with OGTT, is diagnostic of diabetes. If the value,
I was coming to that. That's correct.
100 milligram per deciliter.
So very good. So we have got the introduction towards the fasting glucose and postprandial glucose, and now we have to touch about pregnancy state, because as you know, pregnancy is also having insulin resistance. There are many hormones which play a part in this. So can you just throw a light on the targets which has been mentioned regarding the pregnancy for diagnosis?
Yes,
diabetes.
a fasting value in pregnancy should be less than 95 milligram per deciliter, and 1 hour value, the 1 hour postprandial value should be less than 140, and 2 hour postprandial value should be less than 120 milligram. And the A1C target, so in pregnancy, it tends to be lower in pregnancy. So the A1C target should be less than 6.4%, less than 6% ideally. But in those patients where we cannot avoid significant hypoglycemia, the A1C level is or the A1C level can be set below 7%, but it can always be individualized and customized as per the latest ADA recommendations. And for those diabetes patients, the A1C target is less than 7%, but here also the targets can be individualized, the goals can be individualized based on the comorbidities, the hypoglycemia unawareness status. If the patient is having some hypoglycemia unawareness, we need not stick on to the ADA recommendations. And for those patients who are having a very good control, we can aim for A1C target of less than 6.5%. So it can be always individualized.
Correct. So I think we have heard the initial brief about how the fasting glucose and postprandial glucose now. And we also know that fluctuations of glucose are very high. I recently had a patient of fasting value high, but the postprandial glucose low value. So there are very conditions where they have going fluctuations in the same patient on different days as well. So the type of diet is also important. What diet they have taken. Sometimes the patient comes without taking the medicines, and postprandial glucose, we are not having the medicine and the food with it. So once you diagnose diabetes, no need to have anything like that. But once you already have a patient with diabetes in him, that person we need to have a value with the medicine also taken of postprandial. And regarding the fluctuations, I have to touch about the oxidative stress and the fluctuations, because we know that oxidative damage is produced and complications in the long term by these fluctuations. So who other than Dr. Jyotidev sir to touch about the values of HbA1c. So sir, can you just help us with the HbA1c, why this is one of the major steps in clinical trials, and why is it considered as a surrogate marker and an endpoint in most of the studies and clinical research?
Well, thank you. Thank you, Dr. Mohan Shenoy. Because we have included this topic, because we haven't included such a topic in any of the CME programs. I don't think anybody else have included the glucose monitoring terminologies, because there was a stimulus to include this. In a very recent program, I found that some of the doctors, even the senior doctors, were confusing between SSMPG, SMPG, the TIR, HbA1c. So it's all confusing now, because when we have more of devices and technologies coming up, when compared to more than 50 years of only urine glucose monitoring, now it's confusing, because all the older ones are also existing. And the A1C has been there for more than 25 years now. And that has been the endpoint for both the clinical trials, because we go by the A1C for all the clinical trials. And in clinical medicine also, when the patient is coming, we will do an A1C and decide on whether the glucose is under control or not. So this is the 3 months average glucose value, as you said. But when you look at the statistics in India, there are many geographical locations where there are hemoglobinopathies. Correct. And there the A1C is going to be wrong. And the pregnancy that Gopika just spoke about, the A1C can be wrong. And only in the initial stages we can do the A1C. When there is hemodilution, the A1C will be wrong. And that is why we go by only the fasting and the postprandial in pregnancy. Very high prevalence of iron deficiency anemia in India, even in Kerala. Many girls, they have very low hemoglobin. And there again, the A1C is going to be false high. So A1C has got a lot of limitations, but I think all of you are practicing diabetes. All of us are practitioners of diabetes. The biggest hurdle will be getting an A1C done from a better device. Yes. Because when we are using a D10 in our own laboratories, we know that you get the most accurate value. Or the newer point of care machines from the Abbott, you get the exact value, and even some of these factors can be avoided, such as the hemoglobinopathies, and you get a better value in the Affinio and Abbott. But you always remember that the A1C can be done in any machine, which measures your lipid profile, renal function test, and there the results are going to be wrong. So A1C has got multiple limitations, and that is why when you consider the same A1C in two patients, 7.5 versus 7.5 in two patients, and when you do a 14 days of continuous glucose monitoring, or just 4 or 5 days of continuous glucose monitoring, as Dr. Mohan Shenoy just pointed out, the glucose variability will be less in one patient and highly significant in the other patient. And long ago, one of our own friends, Dr. Sheriello, he did experiments in normal people without diabetes, and using clamp studies, he demonstrated when glucose is high for 6 hours versus when glucose is fluctuating, continuously going up and down, 5 millimoles per liter versus 20 millimoles per liter. The fluctuating glucose values or oscillating glucose values results in oxidative stress, endothelial damage, flow-mediated dilatation. So this directly results in vascular complications of diabetes. So this is one entity we are missing. We go just by the A1C and we miss the glucose variability. So that is why the new recommendations are now pointing towards measuring the variability as well in routine practice.
Yes, so I really thank you for that. So we have to go beyond this. So consensus from the advanced therapeutics and treatments for diabetes, that is ATTD. We have been seeing you going. Last time we had seen a video regarding the advanced. So many technologies are coming new. I think last time it was in Vienna. I think Vienna, Rome. I think I just saw. Yeah. So such consensus groups are still there because TIR is a new concept. It is catching concept. So can Gopika just allude and what can be done regarding this? What people should know about the evolution of time in range and why is it important to have a measure of this?
So the recommendations from the International Consensus Panel on Time in Range actually evolved, as you rightly said, at ATTD in February 2019. So a group of clinicians, researchers, and individuals with diabetes came together, and the concept of time in range evolved in this particular meeting. And 10 CGM metrics were identified in this consensus panel. Earlier in 2017, at another consensus panel happened in ATTD, but there were almost 14 metrics which were identified during that meeting. However, in this 2019 meeting, only 10 metrics were de-identified from those 14 metrics, and time in range was identified as one, as shown in the figure.
Yes, yes.
10 metrics were identified, and time in range was one of the metrics. So the consensus panel recommended that the time in ranges and the percentage of time that a patient should be in range for all these time in ranges should be there. As you can see, the time above range, time below range, and time in range, etc. were discussed during this consensus panel, and this consensus panel was endorsed by almost 8 organizations, if I remember correctly, or like the ADA, the AAS, the ISPAD, the AD, the Diabetes Educators, the American Association for Diabetes Educators, etc. So almost all the international organizations have recommended the international consensus on time in range. So I think sir would be discussing more.
Yeah. So I wanted to ask one thing with Jyotidev sir only. What about the estimated HbA1c from this TIR? Is it having any importance? Because as you discuss more about these 10 matrices, can you also throw light on the CGM derived HbA1c value? Is it reliable or not?
Yeah, that is an excellent question. If you ask about the HbA1c and its relevance to Tadej Battino, because Tadej Battino is the first author of this consensus, and he is the one who initiated everything, along with Moshe Philip. So if you ask him this question, because during one of the presentations in our JPF, he was there in our JPF this year. You remember, you have been there. And he will outrightly tell that don't use A1C. A1C is totally obsolete. Just like we say that urine sugar should not be used, because he says, and he is only supporting TIR. But when you are supporting TIR, or when you are trying to estimate the A1C from a continuous glucose monitoring data, remember, all the continuous glucose monitors are not equally accurate. So when you are trying to get the eA1C from the CGM, this is only from the glucose data measured for 7 days or from 14 days. You are trying to get an average of the 7 days or 14 days, whereas the lab measured glycated hemoglobin is an average of 3 months. So these are not going to match, because the CGM, except the newer ones, the others are only for the trend measurement. And that is the reason why this estimated A1C is now replaced by a new term by Bergenstahl, because I was fortunate to review that article for Diabetes Care, and this is the new term, that is the glucose management indicator. And glucose management indicator will use a new algorithm. And these are all algorithm based, because even the AGP is also algorithm based, and EAG A1C is also algorithm based. And using a new algorithm, this is supposed to give an estimate of only those days of monitoring, not 3 months. And this GMI is one of those metrics along with the TAR.
Okay.
I think that answers the question.
Yes,
But the message is, don't go by the average A1C in the CGM report.
Sir, what about the other terms, sir, regarding TAR, TBR? So it's self-discriminatory. Yeah.
Yeah. So our intention is so that the doctors in all the specialties will get accustomed to this terminologies. So I will briefly go through the terminologies here. The 10 key metrics listed here. Number of days a CGM bond should be 14 days. So the sensor should be there for 14 days, and of the 14 days, 70% of the data is required, because some of the CGMs may not work for during the last 2 days. You know that the first 2 days may be wrong for some CGMs. And then mean glucose is there, GMI is there, glucose variability is there. Lower the variability for those patients who are on drugs more prone for hypoglycemia. And I think these 5 are the most important metrics.
Yeah.
The time in range between 70 to 180. And then level 1 hyperglycemia and level 2 hyperglycemia, above 180 and above 250. And level 1 hyperglycemia and level 2 hyperglycemia, and that is below 70 and below 54. And I will go by the numbers here, because you said about the ATTD. ATTD
yes.
Last year was in Vienna. This year, the ATTD in Barcelona,
Paris.
Spain.
Barcelona, yeah.
Barcelona. So we presented this paper, that is the Asian data on the correlation between A1C and time in range. Because you know that Vygotsky was there for the JPEF in 2018 when you were also there. You could have met Vygotsky then. And Vygotsky presented this data along with McMohan on the correlation and the relationship between TAR and A1C. So when A1C is around 7, the time in range is above 70%, both in type 1 and type 2 diabetes. And with every 10% improvement in the time in range from 70% to 80%, or when you are successful in making 80% go up to 90%, then there is a proportional reduction by 0.5 to 0.8% in the glycated hemoglobin. So this is our data from India, closely correlating with the Caucasian data. And I will go for the most important numbers, which could be the messages for the evening from this program on the nomenclatures. And this is the time in range above 70% for those with type 1 and type 2 diabetes. And when we are corresponding with our patients, when we are communicating with our patients, this 70% means it is more than 16 hours, 48 minutes. And the time below range should be less than 1 hour, and that corresponds to 4% below 70 milligram. And below 54, which is level 2, more dangerous hypo, should be less than 1%, which corresponds to roughly 15 minutes in 24 hours. Time above range, probably you need not by heart it, because these two are the most important entities. You try to be more time in range and less time below range. And one more important point I will touch upon. There is no definition of elderly here. It is the biological age, not the chronological age. And more than 50% is the time which is recommended for the elderly in time in range. That is corresponding to 12 hours. And there is only one level below range, that is below 70, less than 15 minutes in a day. And this is the time above range. There again, only above 250, because we are aiming only 50% time in range. And that should be less than 2 hours and 24 minutes. And of course, we have separate targets for pregnancy, like this, 63 to 140. So pregnancy is, of course, a very important area, which probably in India, especially in Kerala, we are not focusing. which I believe we should be giving more significance in treating diabetes in pregnancy, which has been highlighted by the other friend as well, Dr. Arun Menon. It's so sad that more than 50% are having GDM now. That is the statistics given by some of our colleagues, gynecologists. And this is an area where we can have a publication as well. Mohan Nair is also listening to this. Indira Madam is also there. And subsequently after this, we will discuss on this. Okay. Over to
Yes.
Dr. Mohan. Thank you.
Yes. So I very nice. I think this is a good thing because many people very benefit from such a delightful discussion. So going further, Gopika, can you touch about SMBG? It is a traditional standard because we used to have a glucometer. Previously, person in the Gulf brings a glucometer, gives to the patient, and they don't have the strips for that. So now it is gone because all the people are buying from here, and making in India is also a trend now. So can you touch on the self-monitored blood glucose, how they can do it, and how it's important telemedicine time also, because now we have a lot of patients who can really have a view on this as well. Can you touch about this, Gopika? SMBG?
Yes. Yeah, SMBG is basically testing and recording the blood glucose at different times of the day by a patient or his caretaker at home or in the clinic or in the hospital. So there is a more structured term which is called the structured SMBG, where they monitor the blood sugar levels at predefined intervals, at predefined points at different times of the day, so that the patient and the clinician will get a predefined value during a specific set of values throughout the day, so that some patterns can evolve out of this, and glucose management easy with the pattern management. And this of course can be done with SMBG, with glucometers, or with continuous glucose monitoring as discussed. And if you go by the guidelines by the International Diabetes Federation, we can suggest to the patient on a staggered meal pattern depending on their lifestyles, depending on their work schedule, etc. So we can suggest to the patient for a 5-point SMBG or a 7-point, or in clinical trials we can go by the 9-point SMBG. So these are various recommendations given by the international organizations on when a patient should monitor. And even the latest RSSDI recommendations on consensus guidelines that has come up for SMBG monitoring in type 1, type 2, and even in pregnancy, they have they discuss comprehensive guidelines on how and when the patient should monitor the blood glucose values. And they have, if I remember correctly, they have given different tables where well-controlled diabetes patient, uncontrolled diabetes patient, on insulin, off insulin, all the recommendations for all these patients have been elaborately mentioned by RSSDI guidelines. And if you ask me about my experience, we have been practicing SMBG for more than 20 years now, for over 20 years, using telemedicine. We have a unique software where we ask the patient to report the 4 blood sugar values to us, and based on the values reported by the patient, we will be titrating the dosages of insulin and all the other OHAs and the other medications. And the patient, we would be setting targets for the patient, and based on the target values, we'll be titrating the dosages of the medications, and diet and lifestyle advices would also be provided to the patient. And especially during this COVID times, this has been found to be really effective, because the patient need not come to the center. We can have virtual consultations based on the values reported by the patient. We can show the trends using our unique software, and definitely there is a need for a multidisciplinary team to work with the telemedicine system, so that all these work in unison. And going by the IDF team, the nurses, diabetes educators, the dietitians, pharmacists, psychologists, all of these play a vital role in diabetes management, especially if the patient is on self-monitoring of blood glucose. It's practicing self-monitoring of blood glucose.
So most often we do it in outpatient settings, but in inpatient settings also, this self-monitor of blood glucose is very important. Because patient is in the ward or the ICU. I remember we had a DKA case when I was in residency, diabetic ketoacidosis. We could not actually get the values of the random glucose done. So we usually did the values from the finger prick and did it. But when the patient was discharged, we had only one value which was showing normal value. So the patient came back, just asked me, doctor, I have only one normal value which is shown. So that's one policy about the SMBG. Whatever we document, it has to be documented in a paper or wherever we are putting it in the software. because the self-monitored glucose or whatever capillary glucose values have to be strictly controlled, because we have to be vigilant about what we are measuring as well. Many gadgets are there which are giving non-accurate values. There are inferior technological things as well as the newer technological ones. There is a big variability in the SMBGs as well. So, Dr. Jyotidev sir, regarding your view about the plasma glucose and capillary glucose, because that is a basic question in biochemistry, can you just touch upon that?
Yeah, sure. I will ask you also the answer, because you are also using glucometers very regularly. Earlier days when we are using the glucometers never used to give you the plasma value. It was the capillary value. But it was around 2007, 2008. The glucometer strips used to be plasma calibrated, and then the entire system, the meter strips, all those components used to be plasma calibrated. So now, before that, we used to have a calculation. We used to have a factor multiply to get the plasma value. So when coming to the plasma and the capillary, now is the same. And the importance here is, when we are measuring the fasting glucose value, it is better to measure with the glucose meter, if the glucometer is there. Because when I am using because this is a discussion terminologies, glucometer is the first meter that aims reflectance glucometer. And the others are actually subsequently, they are glucose meters. The first one is named as glucometer. And the same with continuous glucose monitoring system. CGMS is the name of the first system. And subsequently, the technology is continuous glucose monitoring. But now we are using it synonymously. All the devices we are calling it as CGMS. Actually, CGMS is the name of the first device, CGMS Gold. Because I am still preserving that CGMS Gold in our technology museum. We do still have the same device with us. But glucometer is still there in the market, and glucometer is the one which is from the original one. The original one is now the property of Ascensia. It is now procured by Panasonic. So when you are having a discussion with contour glucometers, it is the glucometer. All the others are glucose meters, ideally. And the accuracy of the glucose meters is also a big headache. We were discussing about the accuracy of CGM devices, but all the glucometers or glucose meters are not equally accurate. So there again, you have to be extremely careful when you are relying on the glucometer for making the modifications in the drugs. They are giving you the plasma value, all of them, but some of them are ISO 2003, and the newer ones are ISO 2013 specification. And the ISO 2013, if you go by those standards, because you know the accuracy of the glucometers are measured with the help of Park error grid zone, comparing with the YSI standard or with the standard laboratory. And you pair the samples, and then you will get a zone. And the newer ones, if you consider A and B zone, almost 99.9% of the values are falling in the zone A and B for the 2013 standards. And the newer branded glucose meters, when I say newer branded glucose meters, the price is somewhat matching. The price is not that very high. And you were discussing about getting a report from the SMBG. And these meters, since they are connected to your smartphone via Bluetooth, they are providing you with a report which is so extensive over a period of 4 weeks, 8 weeks, even 6 months. And this digital glucose reports are also having color coding. So at a glance, you can find out where are those red spots, the problem areas, hypoglycemic areas, hyperglycemic areas. So glucometers have also advanced a lot. But subsequent to our initial discussion on insulin intensification, Dr. Prashant is also here. The use of glucometers is also less. And when the pregnant ladies are getting treated, 99.9% of them are not taught about the use of glucometers, because that is an area where they should be regularly monitoring multiple times, and even 1 hour, 2 hour value is much lower than the usual ones. It is 140 and 120 as said by Gopika. So without monitoring, how can you reach? And these are the same lab measured values that we are now procuring with a better glucometer. So we are discussing one of the basic topics in diabetes. and this need to be spread widely among the doctor community. Yeah.
I think we have discussed a lot about the glucometer, HbA1c, and more about the CGMS. I think we should also know about other devices. I think recently type 1 diabetes having sensor, even including pump and also sensor. There are many advantages of using a type 1 diabetic patient with a pump and using a sensor compared to those with. I had a debate with a doctor recently in a scientific forum, because the SMBG measured with the glucometer with the pump with the multiple daily injection, that is very painful also. It contains a lot of pain to prick the insulin and prick the needle as well. And whereas the other side, using a pump with a sensor confers a lot of advantage in quality of life also. That is one aspect I find patients also getting benefit. So I think you also may be agreeing to that. Sir, we are coming to the last part. Regarding the IPDM, sir, you may have a word on that as well, sir. IPDM, integrated person.
Yeah. So that is again an extension of the self-monitoring blood glucose. Because IPDM and the SSMBG are closely related, because Gobia has been discussing about structured self-monitoring of blood glucose. So when we are advising blood glucose monitoring for a patient, it should be structured. If it is not structured, then there is no value. It is useless, because most of the patients stop monitoring the glucose values because the doctor doesn't do anything with those glucose values. Actually, it's not the doctor, it should be the diabetes nurse or the educator. So when they are coming with the big data, the data need to be utilized, or it need to be utilized over the phone or the telemedicine for real-time changes. So SSMBG, as described by Gobika, is a systematic, structured way of monitoring the glucose. Fasting, postprandial, and certain values on Monday, certain other values on Tuesday, or depending upon the type of diabetes, more frequently or less frequently. Whereas IPDM is integrated personalized diabetes management, IPDM. And integrated personalized diabetes management is having everything educated during the first visit itself, training the patient, and then personalizing the goals, because every patient will have a different goal. So it is personalized management, and this personalization is again for the frequency of measurement of glucose values. And then automatically you are integrating this into a system. All the glucose values are getting into a system and automatically analyzing the glucose values for better decision making. So ultimately, the glucose values need to be there in a system. It can be an electronic system, or it can be there in your own electronic records, and this should be there for a personalized decision making. And this should translate to better outcomes. And ultimately, the last step is periodically you have to reassess the IPDM targets, so that every 2 or 3 months you should be reassessing for changing your targets and changing the frequency of monitoring. And though we are in a current era of continuous glucose monitoring and very advanced monitoring, still we are supporting SMBG, and we are discussing IPDM for SMBG because this is the one which will be used by the majority of the patients. More than 99.99% of the patients will still use only SMBG, and that can be easily integrated with some of the mobile phone apps such as MySugar, and also with the integrated personalized diabetes management. And among the IPDM softwares, the cheaper ones, not cheaper ones, the free software is, I believe, MySugar, where you can log in the insulin data, the oral medications, and this has been founded by one of the type 1 diabetes patients. Because you could have seen that video, one of the HTTP video that I have posted, I think that was in 2017 or so. And this has been sold now to Accucheck. So some of these glucose meter data will also automatically transfer to the mobile app. And the latest in the market currently is the Freecell Libre. Freecell Libre, I think I have shown Freecell Libre several times. We have
we should have a demo of this. We should have a demo of
so this is the Freecell Libre reader. You can see the reader over there, and the reader can check glucose within a second. And there is also a mobile app, and the mobile app is Freestyle Libre link. You can see the yellow color over there. And this is the mobile app. And mobile app is currently not available in India. And the mobile app is also a very useful one. The mobile app shows the average glucoses. Can you see this?
Yes, sir. Yes, sir.
And unlike the reader, you can click over here to share the information with your doctor, or you can email, or you can WhatsApp.
Very good.
And this mobile app will reach India, and this also got an estimated A1C.
Oh.
The reader doesn't have all these options.
Yeah.
And this has got this thing, and then the time in target options are there, because don't look at this, because I have this is my own sensor, because here the target is up to 140. Since I don't have diabetes, the target is 70 to 140, and this gives time in range for 7 days, 14 days, 30 days, and 90 days. And the same option is there in the reader. The Libre link will not work in India because I got it because I was traveling somewhere else. And for India, the app will work only for the Indian sensors. And this Libre reader, I think the most important use, I can show you some pictures over here. Is it visible over there?
Yes, sir. Yes, sir.
I think when I'm doing a demo, I think this is the message that I would like to convey. Something which is new should be used immediately, or else we are not providing the best for our patients. Of course, this is a little bit more expensive, but if you look at the ADA, you are supposed to give the ambulatory glucose profile report along with the time and range to every patient with diabetes. So these are the 2020 recommendations, if possible. And these are some of the pictures, snapshots from the Libre reader. The glucose is remaining stable at 401, and there is a trend arrow pointing upwards. And when there is an upward trending arrow, the glucose is rising at a rate more than 2 milligram per deciliter per minute. And when there is a slanting arrow upwards, it is changing at a rate between 1 to 2 milligrams per deciliter per minute. It also provides you with a daily graph, and this is the time in target, time below target, and time above target. So in a motivated patient, so that is what I understand, because we have been using it in around 50, 60 patients now in the beginning. So those patients who are very much motivated, what I have seen is when properly trained, they are very successful in reducing the dose of insulin by more than 20%. And they will try to split their meals. They will try to exercise at some odd hours, because many of these patients are exercising only in the morning. But when they see the trend arrows, afternoon or night, they will split not only the diet but also the exercise. And in 14 days, they will be highly successful in reaching time in target of more than 90%, and time below target 0%. In the first 7 days, they will be failing, because first 7 days will be something for them to learn. And beyond that, most of the brilliant patients will try to manage themselves. So this is a consumer product meant for patients to procure and use it for themselves. And of course, we should be supporting them. But this is a game changer wherever it was launched. And it has reached India 6 years late. 6 years late only because the demand was too high, and they couldn't provide the device for a huge population such as in India. But we are expecting the app and the downloadable software very soon. And this will work along with something called a Libre View. And the Libre View will be available for V doctors. So that is in summary about the glucose.
Yes, sir. So I think most of us would have been benefited. And I think this is available on YouTube also. I think the program will be available afterwards also. So I think that will be beneficial for the education as well. So I think we have covered most of the discussion, sir. I think I should thank both of you for having spent the evening. I think I was very happy with the quality of the real presentations as well. So just to set the tone of what we have discussed so far, I would have my concluding section. So I think we have had a lot of discussion regarding the glucose monitoring techniques which have been evolved across the history from the urine glucose, like a measurement, to the capillary glucose and the fasting and the plasma glucose, and now to the sensor-based technologies. So technology is most important because now we are going to smartphone. We are not using the traditional type of technology. So many things we are actually learning with time. So we have, this is all part of the glucovigilance. This is the concept by which we are monitoring the glucose properly. We have got a lot of terms. I think more the merrier. The lot of drugs as well, the more the merrier. So I think we should all embrace technology. We should learn from the leaders, and we should always try to help each other out when we don't know much about anything. So I think with this, I would really like to thank both of you. I think we should say some questions also at the end. I think we have a question from Dr. Ramesh Nair. Will insurance companies reimburse? I think that is the one question I think we should all ask the. Is there any possibility, sir, regarding?
I think this question was for the previous panel, not this panel. And Mohan sir wanted to answer this, right? Mohan sir has indicated that he wanted to answer or something. I saw that.
It was by mistake. I wanted to type a question and.
Okay, sir. Because insurance companies, for type 1 at least, we are all trying for Libre, because Libre is provided free of cost by the government in most of the countries, because this is just to reduce the cost. Because if you are trying to monitor the sugars properly, and if you are initiating insulin early, then the cost is going to be much less, maybe 10 times less compared to treating coronary disease and chronic kidney disease in diabetes. Very simple, very simple. But you require a team. Without a team to support, it is impossible. Because even in Libre, we have seen that 24/7 support is required from our team. There are 2 people working. Lot of questions are there for the patients. And when they are using it for the first time, because we have been training over the video on how to apply. And then some of the sensors will fail, because it is natural for some of the sensors to fail after 2 or 3 days. Sensor failure is still there. Because all the technology, any technology can fail, even for a new car. That is inevitable. Likewise, Libre, it has been there in the market for more than 6 years, but still, it is the Libre 1.0 which is there in the Indian market, not Libre 2 or Libre 3. So in the developed countries, they have Libre 2, and in some European countries, they have Libre 3. Libre 3 is 70% smaller. So the gadgets are currently not provided by the insurance, but if we can all be struggling for that, but ultimately the doctors need to use it, because the focus of insurance is on reimbursing for complications, not for preventing the complications. And that has been true even in the US. That's a sad situation. Any comments? Unmute, Mohan, yeah. Dr. Mohan, you are not audible.
Yeah.
Yeah, please.
Yeah, you can hear me now. Yeah,
please.
So I think we have come to the conclusion, sir. I think we have almost had a long discussion. I think we have spent close to 45 minutes. So I think we have, we have finished the discussion, sir. So we should have more comments from the others in the meeting. I thank both of you for having spent the evening with me.
Thank you, Dr. Mohan, for joining us. Brilliant moderation.
Thank you so much.
Mohan sir, any comments from you?
No. Yeah, it's actually regarding GDM. Because we are speaking about say glycemic goals, all these things, but unfortunately Kerala, we don't have a, I think we don't have a GDM registry. Do we have one?
No.
It is a very poorly controlled disease in Kerala. Very badly managed.
Yeah, and actually the health system, way back in 2010 or 2008, we proposed, actually Shedai sir knows the whole history, because we were successful enough to get funding for that particular project to establish a GDM registry at least for Trivandrum district. But the then minister was not convinced about the whole issue, that he diverted the whole money for sickle cell anemia Bodhavalkaranam to Wayanad. So the money, yeah, the money was channeled to sickle cell anemia Bodhavalkaranam. Our money, are sickle cell Bodhavalkarichunu, nobody knows even now.
Hemoglobinopathy, hemoglobin
Exactly.
A1C.
So, yeah. So what happened was, at least we could have started a registry at that time. Then our idea was to spread it that to the whole state. But unfortunately, after that, nobody is taking an initiative on that. We have to have a sort of proactive thinking, and also we have to lobby in such a way that it's actually a disgraceful that a state like Kerala doesn't have a gestational diabetes registry. So I think we have to think along those lines now. It's actually a
We should-
request to Jyoti because
yes. You should
can
show the
take
way, sir.
Yeah.
Ashwin, you will have your own experiences from acting, and I remember you telling me.
I was also thinking because last month we got a paper published with Sir and Dr. K.L. regarding the same thing. Actually, in that paper also we were discussing on the same thing, because most of the time it's what we see in our like when I treat patients in Artingel, most of the diabetes GDM are not actually, they are not GDM, they are actually T2DM. Because there has been any of a blood testing done at the initial stage. There hasn't. Most of the doctors see only their fasting blood sugar and conclude that it is not. It's just the patient is safe or doesn't have any of the disease or anything. So I think we have to advise all the patients to at least do HbA1c at the initial time during the initial diagnostic period, so that we won't miss a T2DM, and we will be more cautious in treating these type of patients. So that is what my comment is on this.
Thank you, Gopika. From this panel, we can have a publication on some GDM recommendations.
Sure, sir, sure.
We have initiated some time back, but the science of GDM should come throw light again, because in Kerala, when compared to Karnataka, because I know the situation even Tamil Nadu, the gynecologists need to refer to the diabetologist. Yeah, excellent. GDM is a specialty there, and here it is not, because I am telling Gopika because Gopika used to have GDM, and and she was on very tiny doses of insulin, and subsequently almost 80% of the GDM patients, even though the diabetes disappears, they will be diagnosed with type 2 diabetes, and that diagnosis is also very late. Very late. They come with complications. And I am 100% sure that Prasad Shankar will have so much experience in Pathanamthitta.
Yes, sir. Definitely. This is again something which I wanted to talk to some August audience like this, because we can, it's very, I think it's time that we start a statewide registry on gestational diabetes, especially because we have a lot of this fertility related hospitals which are there, which are managing a lot of patients with diabetes and gestational diabetes. So it would be much easier to gather the data from different parts of the state. So I think it's high time that we start a registry on gestational diabetes, and can track the patients for developing type 2 diabetes in the future also.
Yeah,
so,
another thing is that these people actually really get lost after the delivery.
Yeah.
In the rural setting, what we see is almost the almost 60 to 70% of people who turn up after GDM with type 2 diabetes had never been followed up after delivery. Probably many of them had never been followed up. And, we have a very, very closely well-knit primary healthcare delivery system. So if you have a GDM registry, it is very easy to link that primary care system with that GDM registry, so that our JPH and JHS, ASHA workers, they will monitor the ladies in the field. But unfortunately, that's not happening, because this message is not being sent to them that there is a lady with GDM. The lady needs to be monitored even after delivery. That message is not reaching the community.
Exactly. Because for the lady with a pregnancy, her only objective treating diabetes is to have a delivery. And once the delivery is over, her job is over. She forgets about it. And now it is then only the child. But the problem with the GDM is the child will develop diabetes later on, and the lady will also develop, almost 100% of them will develop type 2 diabetes. And they are not taught about healthy eating. They are not about reducing the body weight, nothing. And they will gain weight again and again in the next 2 years' time, and subsequent to next delivery, it will be fully established type 2 diabetes. Very sad state of affairs. So thank you so much. Thank you. Over to Govika.
So now we have come to the fag end of our CME. So now I humbly request Ms. Sunita Jyotidev, our Executive Director. I humbly welcome Madam for the vote of thanks. Ma'am, you're muted.
Good evening. Can you hear me?
Yes.
Okay. So, respected faculty members, delegates, and dear friends, we are actually come to the end of today's JPEF virtual CME this evening, and I would like to thank Dr. Mohanar sir for accepting our invitation and being part of the CME and inaugurating this evening CME. And I offer our sincere thanks, dear sir. And our special thanks to the better half, Dr. Indira Madam also, for being with us the whole evening. And we had an excellent array of sections today evening. And first one was the topic on influenza vaccine in diabetes. It's beyond flu shot. And our sincere thanks to Dr. Arjun, who had accepted our invitation and being part of the CME this evening. We had an excellent discussion, and I sincere thanks to Dr. Arun Shankar, our medical director, for moderating. And as you all know, the theme of this evening is 100 years to insulin. And as we all know that, we will be commemorating the centenary of 100 years of insulin soon. So as part of this, the highlight of the CME this evening is 100 years to insulin. And the panelist was Dr. Arunas Menon, consultant endocrinologist, Lisi Hospital, Kochi. And our sincere thanks to Dr. Arunas Menon for accepting our invitation and being part of this evening CME. And sincere thanks to Dr. Jyotidev also. And I would like to thank the moderators, Dr. Prashant Shankar, consultant internal medicine, doctor from Muthoot Medical Hospital, Pathanamthitta, and our center head, Artingal JDC, Dr. Ashwin David, for being with us this evening. And last, we had a very brainstorming discussion on demystifying the glucose monitoring terminologies. And we had an excellent discussion covering almost all topics on continuous glucose monitoring this evening. And I would like to sincerely thank the moderator, Dr. Mohinti Shinoy, consultant endocrinologist, Gokula Medical College and GG Hospital Trivandrum, for initiating the discussion and covering almost all the topics. And the panelist, Gopika Krishnan, our academic head, for giving excellent answers to each and every questions put forward, and Dr. Jyotidev Keshav also. And I would like to thank almost all the participants, who have gathered to listen to our JPEF virtual CME this evening. Almost around 504 participants have participated this evening CME. And this JPEF virtual CME, as you all know, we have conducted as part of World Diabetes Day activities. And as you all know, we have been conducting World Diabetes Day month activities for the past more than 20 years. And this month also, we are having around 32 programs and lineup. And we are yet to have a couple of programs also during the end of this month. And last but not the least, I would like to thank the program coordinators of this evening CME and program coordinator Dr. Gopika Krishnan and Deepu and all the team members who have been behind this CME to make it a big success. And my sincere apologies that we are not able to invite you for dinner as it used to be a customary for all our CMEs in the past. We really miss that. And once again, thank you very much for your active participation and being with us this evening. Thank you very much.
Thank you. Until next CME. Thank you.
Thank you, sir.
Thank you.
Ladies and gentlemen, you have had a long sitting and we hope you enjoyed the sessions. And this was the first series of our 100 Years of Insulin Symposium. We will meet again in the forthcoming CME in December. Till then, stay healthy, happy, and safe. Good night.
Thank you.